Halo, aku Dik Rossi, maskot dari Riset Pengabdian Masyarakat dan Inovasi atau RPMI FKUI. Di sini aku akan menjelaskan tentang RPMI FKUI. Ini adalah struktur organisasi RPMI FKUI. RPMI FKUI dikomandoi oleh Manajer Riset dan Pengabdian Masyarakat, Dr. Rahyu Salim, SPOTK. Sebelum melanjutkan penjelasan, aku akan memperkenalkan kakakku. Namanya adalah Bang Isor.
Halo, aku akan membantu adikku menjelaskan bidang-bidang yang ada di RPMI FKUI. Pertama adalah bidang riset. Dengan jargon, Let's Do Research Happily. Dengan visi. Kedua adalah bidang pengabdian masyarakat. Dengan jargon, Mengabdi Berkarya Cipta. Dengan visi. Ketiga adalah bidang inovasi, dengan jargon Gerak Cepat Program Inovasi, dengan visi.
Tugas utama RPMI FKUI adalah meningkatkan jumlah sitasi, jumlah publikasi, jumlah dosen dengan high index lebih dari 2 atau Scopus, yang dituangkan dalam 45 Key Performance Indicator atau KPI, beserta target yang harus dicapai. Di bawah ini adalah contohnya. Demikian penjelasan singkat tentang RPMI FKUI. Sampai jumpa. Do Research, Social Service, and Innovation.
Assalamualaikum warahmatullahi wabarakatuh.
Selamat pagi,
Salam sejahtera,
Om Swastiastu,
Namo Buddhaya,
salam kebajikan.
good morning.
Yang terhormat Direktur Riset, Teknologi, dan Pengabdian kepada Masyarakat, Kementerian Pendidikan, Kebudayaan, Riset, dan Teknologi Republik Indonesia, Profesor Dr. Insinyur Muhammad Faiz Syuaib, Magister Agroteknologi.
And our honorable guest, Dean of Faculty of Medicine, Universitas Indonesia, Profesor Dr. Ari Fahri Alsyam, Spesialis Penyakit Dalam, Konsultan, Gastroenterohepatologi, Master of Molecular Biology, and the Boards of Deans of FKUI.
Director of IMERI FKUI, Profesor Dr. Badriul Hegar, Spesialis Anak Konsultan, Doctor of Philosophy and Board.
Director of Oxford University Clinical Research Unit, Indonesia, Professor J. Kevin Baird, Doctor of Philosophy, Fellow of American Society of Tropical Medicine and Hygiene.
And all of our professors, doctors, researchers, and all of our esteemed guests.
Esteemed professors, partners, and collaborators of OUCRU Indonesia, including Professor Dr. Amin Subandrio W. Kusumo, Doctor of Philosophy, Spesialis Mikrobiologi Klinik Konsultan.
Profesor Dr. Ayodhya Pitaloka, Magister Kedokteran Pediatrik, Spesialis Anak Konsultan, Doctor of Philosophy.
Profesor Dr. Din Syafruddin, Doctor of Philosophy.
Profesor Dr. Inge Sutanto, Magister of Philosophy, Spesialis Parasitologi Klinik.
Profesor Dr. Erlina Burhan, Master of Science, Spesialis Parasitologi Konsultan.
Profesor Dr. Anda Taniawati Supali.
Profesor Dr. Ratna Sitopul, Spesialis Mata Konsultan.
Dr. Uun Sumardi, Spesialis Penyakit Dalam, Konsultan Penyakit Tropis Infeksi, Finasim, KAC.
Dr. Inke Dinianti Lubis, Magister Kedokteran Pediatrik, Spesialis Anak, Doctor of Philosophy.
Dr. Ana Rozaliani, Magister Biomedik, Spesialis Paru.
Brigadir Jenderal TNI Purnawirawan Dr. Noh T. Malisa, Magister Kesehatan.
Brigadir Jenderal Polisi Dr. Haryanto.
Komisaris Besar Polisi Dr. Joko Navianto.
Kolonel Korps Kesehatan Militer Dr. Abdul Alim, Spesialis Penyakit Dalam.
Kolonel Korps Kesehatan Militer Dr. Jusron Iriawan, Spesialis Penyakit Dalam.
And all professors, doctors, and esteemed guests who have joined us today both in Aula and remotely. Perkenalkan, saya Dr. Devina.
And my name is Naufal. Allow us to lead our event this morning. Esteemed guests, welcome. Today, we are gathered in this room to celebrate the ongoing research collaboration between the Faculty of Medicine, Universitas Indonesia, and Oxford University Clinical Research Unit Indonesia, and the researches and achievements accomplished by our dedicated researchers in our event, the 6th DROSSI Appreciation Day FKUI-OUCRU Research Collaboration. This event aims to disseminate researchers and projects resulted from this collaboration with hope to inspire and open more opportunities for more researchers to collaborate, create, and innovate in the spirit of Tridharma Perguruan Tinggi, Research and Development. Hadirin yang terhormat, sebelum memulai acara, mari kita menyanyikan bersama lagu kebangsaan Indonesia Raya. Hadirin dimohon berdiri. Hadirin dipersilahkan duduk kembali. Selanjutnya, kami mengundang Dr. Zeri Ilham untuk memimpin doa sebelum kita memulai acara relaunching ini. Kepada Dr. Zeri Ilham, kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Marilah sejenak kita bersama-sama menundukkan kepala bermunajat kepada Allah Subhanahu wa taala agar kegiatan kita pada pagi hari ini dapat diberkahi dan dapat berjalan dengan baik. Amin. Allahumma sholli ala Muhammad wa ala ali Muhammad kama shallaita ala Ibrahim wa ala ali Ibrahim innaka Hamidum Majid. Alhamdulillah, ya Allah, Tuhan yang Maha Penyayang. Pada hari ini, di ruangan ini kami hendak menyelenggarakan acara FKUI-OUCRU ID Collaboration. Berkahilah acara ini dengan keberkahan-Mu. Bimbinglah langkah-langkah kami dalam menjalankan acara ini dengan penuh kebijaksanaan, ketelitian, keberlanjutan. Berikanlah ilmu yang bermanfaat, wawasan yang luas, dan kerjasama yang harmonis di antara semua peserta. Ya Allah, kami mohon doa restu agar acara ini menjadi sarana yang membawa manfaat bagi perkembangan ilmu pengetahuan dan kesehatan. Jadikanlah kolaborasi ini sebagai langkah yang membawa berkah, keselamatan, dan kebaikan bagi masyarakat luas. Ya Allah, ya Wahid, Engkau yang Maha Satu dan Maha Mempersatukan. Kami mohon perkuatlah persatuan di antara kami. Janganlah Engkau biarkan ada perpecahan di antara kami. Kami ingin kuat dalam persatuan agar lebih bermanfaat untuk agama, bangsa, dan negara ini. Ya Allah, Ya Ghafur, Engkau Maha Pengampun atas segala dosa. Ampunilah dosa kami, dosa kedua orang tua kami, dosa para pemimpin kami, dosa para pejuang dan para pendahulu kami. Tepatkanlah kami semua dalam lindungan, rahmat, dan ampunan-Mu, dan mudahkanlah setiap langkah kami dalam meniti jalan kebaikan. Ya Allah, Ya Mujib, Engkau yang Maha mengabulkan doa, perkenankanlah doa dan permohonan kami. Rabbana la tuzigh qulubana ba'da idh hadaitana wa hab lana min ladunka rahmat innaka antal wahhab. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Subhana rabbika rabbil izzati amma yasifun. Salamun alal mursalin walhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih kami ucapkan kepada Dr. Zeri Ilham.
Distinguished guests, we will now listen to a welcoming speech from the Dean of the Faculty of Medicine Universitas Indonesia, Profesor Dr. Ari Fahrialsyam, spesialis penyakit dalam konsultan gastroenterohepatologi, Master of Molecular Biology. Please welcome to the stage Professor Ari.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Profesor Dr. Insinyur Muhammad Faiz Suaib, Magister Agro, Magister AGR, the Direktur Riset Teknologi Pengabdian kepada Masyarakat, Kementerian Pendidikan, Kebudayaan, Riset dan Teknologi Republik Indonesia. And also we have Professor Hegar as Director of Emery. And also we have Vice Dean Dr. Anis and representative from Cipta Mangunkusumo Dr. Andri Lubis, Professor Kevin Bird, Director of OUCRU Indonesia, and distinguished guests, Professor Brigjen TNI Purnawirawan Dr. Nuh T. Malisa from KSP, and also our friend from Polri, and also from Army, and Professor, and also we have friend from USU, and ladies and gentlemen. So it is my honor today to welcome you to our Faculty of Medicine this morning. You know, we start using this building 2017. This is a new building. And we have another old building in front. We start using that building 1922. So this is good for you if you want to. Don't forget, after finish this meeting, go to in front of this building, take picture, and as soon as possible, upload to your social media. Mention that we have two new building and the old building. Okay, and then in this moment, I would like to express my gratitude to you all for joining this event, what we call that the DROSSI Appreciation Day for OUCRU Indonesia and also Faculty Medicine Indonesia collaborations. Today it is a celebration of partnership, dedication, and the shared pursuit of knowledge that has defined the collaborative spirit between OUCRU Indonesia and Faculty of Medicine Indonesia. If you can read here what is the Oxford University Clinical Research Unit Indonesia, mentioned that the locally driven research program on infectious diseases in Southeast Asia with local Indonesia, UI, regional, and global impact of health. So I think this is the important mission from OUCRU, why they came here in Indonesia. We know that the collaborations between OUCRU Indonesia and Faculty of Medicine started in 2012. That discussed with Professor Kevin, and has been excellent in the field of medical research. Many publications, many PhD, and many things that we have done. And also, I think in an era where global challenges require global solution, partnership, like the one of Celebrate today, are essential. They bridge boundaries, facilitate the exchange of ideas, and propose us toward breakthrough that can positively impact public health. We have some topics today to discuss about the geospatial epidemiology research, clinical infectious diseases, community health research, and also about the malaria research. I think this event also that we will discuss more about that, and I think and also we can get innovative ideas and the collaboration for better healthcare in the future. I extend my deepest appreciation to all those who have played a pivotal role in making this collaboration success, the researchers, administrators, support staff who have dedicated their time, intellect, and patience to advance our collective missions. To our esteemed guests, I invite you to join us in celebrating not just the accomplishment of today, but the enduring impact that our collaborative endeavors will have on the future of medical research. May this appreciation day serve as a reminder of importance of collaborative partnership in saving a healthier and more resilient world. Thank you for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Ari, for the warm welcome.
Selanjutnya, mari kita dengarkan sambutan dari Bapak Direktur Riset Teknologi dan Pengabdian kepada Masyarakat Kementerian Pendidikan, Kebudayaan, Riset dan Teknologi Republik Indonesia, Prof. Muhammad Faiz Syuaib. Kepada Prof. Muhammad Faiz Syuaib kami persilahkan.
Ya, terima kasih pembawa acara. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam sehat produktif, dan bahagia selalu. Ya tentu pertama puji syukur kita panjatkan kehadirat Yang Maha Kuasa, Tuhan Yang Maha Esa, Allah Subhanahu wa Ta'ala, karena kita masih diberi kesehatan, diberi kesempatan, dan semoga kesehatan kita ini membawa manfaat dan produktivitas bagi bangsa dan negara kita. Ya, yang kedua, tentunya saya hormati, yang saya apresiasi kepada Pak Dekan, Prof. Ari, para tamu undangan, dan juga mitra dari Oxford University atas terselenggaranya acara yang luar biasa pada hari ini sebagai bentuk ekspos ya dari kegiatan kolaborasi yang sudah berjalan bertahun-tahun antara Fakultas Kedokteran UI bersama dengan Oxford University. Yang ketiga, saya sampaikan juga permohonan maaf dan salam dari Pak Dirjen karena ada kegiatan lain tak bisa dihindarkan, tidak bisa hadir pada acara dan undangan hari ini dan menugaskan saya untuk mewakili untuk menyampaikan kata sambutan pada acara ini. Tentu pertama-tama juga saya sampaikan selamat dan apresiasi ya, atas suksesnya kegiatan kolaborasi riset dan juga ekspos hasil-hasilnya, dan juga saya dengan nanti akan ada awarding ya, melalui forum ini yang dilaksanakan oleh FKUI bekerjasama dengan Oxford University. Sebagaimana kita maklum dan kami juga memprofil itu bahwa UI adalah salah satu perguruan tinggi terbaik di tanah air. Dan salah satu dari sedikit perguruan tinggi di tanah air yang berhasil masuk dalam jajaran dan kualifikasi World Class University. Dan secara khusus di bidang ilmu dan bidang fokus riset kedokteran dan kesehatan, tak dilakukan lagi dari rekam jejak yang kami analisis dari profil UI. UI adalah yang terbaik untuk bidang tersebut di tanah air. Oleh karena itu sudah sepatutnya dan seharusnya lah UI senantiasa menjadi yang terdepan, menjadi lokomotif untuk pengembangan riset, pengembangan keilmuan, pengembangan pendidikan tinggi, trendsetter, inspirator, motivator, dan juga mentor bagi perguruan tinggi lainnya untuk terus bersama membangun keunggulan dan reputasi pendidikan tinggi kita. Bapak dan Ibu sekalian, reputasi suatu perguruan tinggi sepatutnya tidak hanya semata dinilai dari seberapa banyak lulusan dihasilkan dan seberapa banyak riset dilakukan, tetapi lebih dari itu, semestinya juga diukur dari seberapa besar semua hasil tersebut dapat menawarkan solusi, dapat diketahui dan diakses, dapat dirasakan dan menghasilkan perubahan bagi masyarakat. Sikon dunia tentu berubah ya, kita mengetahui bahwa begitu cepatnya perubahan di dunia dan semakin cepat perubahan tersebut kita rasakan akhir-akhir ini. Tentu perubahan adalah keniscayaan dan itu semua akan melahirkan problematika dan tantangan. Semakin cepat perubahan terjadi, maka semakin segera dan kompleks pula permasalahan tersebut harus diselesaikan. Untuk mampu survive dan mengatasi berbagai problematika tersebut, tentunya diperlukan pengembangan ilmu terus-menerus, kemampuan untuk menyelesaikan masalah, problem solving, kemampuan untuk menghasilkan inovasi, solusi, dan teknologi yang juga harus semakin relevan dengan kompleksitas permasalahan tersebut. Demikian pula, permasalahan domestik tidak bisa dipisahkan dengan permasalahan global. Demikian pula sebaliknya, apa yang terjadi di permasalahan global, cepat atau lambat, akan menjadi permasalahan domestik. Tidak ada permasalahan yang bisa diselesaikan sendiri. Dengan keilmuan tunggal, maka berbagai permasalahan untuk menyelesaikannya diperlukan kolaborasi dan kerjasama antar ilmuwan, antar institusi, antar disiplin keilmuan, dan seterusnya. Oleh karena itu, untuk bisa membangun kerjasama dan kolaborasi, maka perlu dibuka dan diperluas pintu saling komunikasi. Pintu komunikasi harus dilanjutkan dengan bagaimana saling berinteraksi. Saling berinteraksi akan membangun saling menginspirasi, saling memotivasi, sehingga pada akhirnya terjalin kesepahaman untuk saling bekerja sama. Tentunya kami di Kementerian Pendidikan, Kebudayaan, dan Teknologi, khususnya di Direktorat Jenderal Riset dan Teknologi, senantiasa mendorong dan memotivasi adanya kolaborasi, partnership, ataupun matchmaking dalam kegiatan-kegiatan akademik, dan tentunya termasuk dalamnya ada kegiatan riset, community services oleh insan atau institusi akademik, baik sesama perguruan tinggi di dalam negeri, di tanah air, dan tentunya juga dengan mitra-mitra kita dari luar negeri. Ibu Bapak dan rekan sekalian, Oxford University adalah salah satu perguruan tinggi terbaik di dunia. Demikian pula UI adalah juga salah satu perguruan tinggi terbaik di kawasan, khususnya untuk bidang kesehatan dan kedokteran. Tentunya kolaborasi di antara keduanya akan melahirkan banyak hal, kebaikan dan harapan yang bisa juga akan menjadi role model bagi perguruan tinggi lainnya. Untuk terus membangun reputasi dan sekaligus pula membangun relevansinya bagi masyarakat, sudah sepatutnya lah capaian-capaian yang dihasilkan itu dikomunikasikan, diekspos kepada masyarakat, sehingga apa yang dihasilkan tadi tidak semata-mata berhenti di dalam kampus di antara kita saja. Baik itu ekspos bagi masyarakat sesama masyarakat ilmiah, dan juga tidak kalah pentingnya adalah bagaimana kita ekspos kepada masyarakat secara umum. Sehingga akan terus meningkatkan kontribusi ilmu pengetahuan dan teknologi yang dihasilkan oleh perguruan tinggi untuk bisa menawarkan solusi dan membangun harapan dan optimisme bagi bangsa dan kemanusiaan. Forum demikian ini adalah contoh praktik yang harus senantiasa ditumbuh kembangkan oleh segenap insan dan institusi akademik. Ibu dan teman-teman sekalian, akhir kata, sekali lagi kami sampaikan selamat dan apresiasi yang setinggi-tingginya atas inisiatif yang telah dilakukan, atas sustainable collaboration antara UI dan Oxford University, serta penyelenggara forum expose capaian dari hasil-hasil kolaborasi tadi, serta awarding bagi mereka yang berkontribusi atas capaian-capaian ini. Semoga UI terus semakin maju, semakin bereputasi, semakin menginspirasi, dan berkiprah lebih luas lagi, dan tentunya impactful, baik itu di kancah domestik, lebih terlebih lagi di kancah global. Demikian Ibu Bapak sekalian, sekali lagi selamat. Semoga apa yang dilakukan ini menginspirasi dan terus akan menghasilkan kebaikan bagi bangsa, negara, dan umat manusia secara keseluruhan. Demikian yang bisa saya sampaikan. Mohon maaf apabila hal kurang berkenan. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih banyak Prof. Faiz Syuaib atas sambutannya.
Our first presentation will be brought up by Professor J. Kevin Baird as the Director of OUCRU Indonesia regarding the overview of OUCRU history and operations and partnership of OUCRU and FKUI. Please welcome Prof. J. Kevin Baird.
Ya, terima kasih. Prof. Faiz Syuaib, Dekan Audi, Wakil Dekan Salim, and Prof. Hegar, terima kasih. Ya, untuk semua ibu-ibu dan bapak-bapak sekalian, teman-teman dan kolega-kolega, terima kasih atas kesempatan untuk menjelaskan hubungan antara Universitas Oxford dan Universitas Indonesia sehingga kita dapat berkolaborasi dan berinovasi dengan lebih baik. So I'll get started with really just, I want you to understand how we work. It's not just about the relationship, but how this unit operates. And that's to enable you to better understand how we work to, as I said, to improve collaboration and innovation together in partnership. As Dean Ari just highlighted appropriately, locally driven, that's you. That's your health problems, your health priorities. We listen, and that's how we collaborate. Is this supposed to work? This is not advancing. Okay, now just in the broadest terms, what is OUCRU Indonesia? We are operated and governed by the Center for Tropical Medicine and Global Health at the Nuffield Department of Medicine at the University of Oxford. You can read all about it at that simple link. You can Google it as well. We also receive a great deal of financial support from what's called the Africa-Asia program of the Wellcome Trust. Wellcome Trust is a very big organization. They do many, many, many things. This Asia-Africa program is actually a small slice of what they do. And you can learn more about that specific program. And I'll talk more about it in terms of how we operate. But in plain and simple language, what OUCRU Indonesia is a private, not-for-profit, foreign academic entity engaged with our Indonesian partners in the joint conduct of clinical biomedical research enterprises, specifically infections, and I'll go more into detail on that. First, just a quick understanding of who we are, how we're governed. You can see on this map on the right-hand side that there's people in Oxford we answer to, and an organization there that governs us. Richard Cornell is the head of the Nuffield Department of Medicine. He is my boss's boss. Brian Angus, he's the director of the Center for Tropical Medicine and Global Health at Oxford. And you can see in the diagram to the right corner, it's a quite complex organization with Brian's Center for Tropical Medicine and Global Health in the center. And you can see that there's three branches off of that. There's KWTRP, that's the Kenya Wellcome Trust Research Program, funded again by the AAP of Wellcome Trust. There's MORU, which is the Mahidong Oxford Research Unit in Bangkok. They have a number of branches: Cambodia, Congo, Myanmar, Laos, Thailand, including Bangkok and Mae Sot. And then OUCRU, which is our home. You can see that it has laboratories in Indonesia, Nepal, and Vietnam. And there we are, the Indonesia branch. This is the OUCRU program, the one based in Vietnam and operating in Nepal and in Indonesia. Professor Guy Thwaites, he's my boss. He sits in Ho Chi Minh City. My co-directors of other units are Rogier Van Doorn in Hanoi and Abhilasha Karki in Kathmandu. And I'm just highlighting some of the areas of research undertaken across the program. You can read them for yourself. And also perhaps appreciate that they are very much infections focused. This diagram is actually taken from our Wellcome Trust proposal, or to describe to the Wellcome Trust what's important to us. It's a very busy slide, or diagram, but in general, you can see the blue box in the center says patient-focused research, and the green box says population-focused research. So we do both. But in the center of them is the pathogen, the patient, and treatment or prevention. And you can see our desired outcomes there on the right. This is how OUCRU Indonesia is organized. I am, of course, the director. And you can see that we have 4 major branches. One does the research, another does the research services, finance, and operations. None of these could function without the other. We can't do research without services, both research and finance and operations. These are all vital pieces of getting the work done. I think operations and finance speak for themselves as to what they're about, but research services, I'll just spend a minute on that. Clinical trials operations, Dr. Mutia heads that up. Laboratory services, Dr. Desi. We've just hired Rani, our new research grants and contracts manager, and Ragil is our public engagement. And you'll be hearing all about the research programs a bit later. I've taken this from the FKUI website to show you in your own organizational organogram where we fit in. You can see it there for yourself. In terms of our physical locations, where are we sitting? You can see the ground floor of Ameri. We're in 2 of the 4 corners. Our doors are open. Come see us, visit us. We also have a longer standing facility over in Parasitology, across the way over there. We call that OUCRU. And the clinical trials unit, public engagement sits there, as well as our only actually dedicated laboratory space for our clinical trials. But we also share integrated laboratory space in the infectious diseases cluster on the 12th floor. And as you'll see in a moment, we also do quite a bit of work in the field. So almost on any given day, a lot of our people are at remote sites. These are the essential statistics. We currently employ about 120 full-time staff. Most of those positions, 80%, are funded by specific projects of defined endpoints. And I'll give you more detail on that in a moment. 97% of these positions are locally hired staff. We're almost entirely Indonesian. Just a few orang asing here. 65% of those positions are technical and 35% are administrative. varies from year to year, but our annual spending ranges anywhere from $2 to $6 million. Publications, this is since our inception in 2008 as the Eichmann-Oxford Clinical Research Unit. And you can see that over the years, our output has grown quite a bit. And if you looked at the funding, it would look the same. I don't have that graphic. But you can see that in recent years, we have been doing quite a lot of work with our FKUI partners. And we're publishing quite a lot of work. That's a total of, in 2022, that was 54 publications, with 19 of them with FKUI co-authors. And we expect that number will increase very substantially. The green you see there is a preliminary number. And since we are now formally affiliated with FKUI, all of those are FKUI publications. Just a photo gallery of our friends in FKUI. We've been working with some for many years, some recently. You all know these folks. I don't have to name them for you. But just to make the point that we work with very many faculty members, both senior and junior. I'm showing you this project map simply to make a point that the 4 programs you'll be hearing about, community health, geospatial, malaria, and clinical infectious disease, none of us operate separately. We share resources, we share laboratories, we share technicians, we collaborate directly with each other and our partners. And this diagram really makes the point that we are not stovepiped into different programs, but really working together and sharing what we have to get the job done. This is where we have recently worked, an amazing number of different sites and different projects. This is one of our strengths. We have the ability to work at remote sites, both with our people and with partners we engage entirely at remote sites. Just want to talk about funding. So as I mentioned, our core funding comes from the Wellcome Trust Asia-Africa program. Now this is used almost entirely to support the capacity to do research. It doesn't support research, it supports the capacity to do research. So that actually doing the research, the projects you just saw the maps and the diagrams for, that actually requires us to go out and seek external funding from sponsors of biomedical research. Sometimes it's the Wellcome Trust, most times it's not actually. In a typical year, for every $1 of core funding we get on our AAP Wellcome Trust grant, we generate $2 to $3 of competitive external funding from very many sources, and I'll show you those in a second. So our research funding is always temporary, and it's very specifically tied to deliverables to the sponsors of each single project. Nobody gives us money for capacity building except the Wellcome Trust in our core grant. So let me just make one more point here. That doesn't mean we can't capacity build. Every project we win and we conduct, we buy things and we learn things and we gain reputation. That's capacity building. So successful research, even though it might have a narrow focus and a deliverable to a specific sponsor, that's capacity building, and we approach it that way. This is the mixed bag of funders that we have recently successfully won support from. Wellcome Trust, Bill and Melinda Gates, Medicines for Malaria. We're now working with the European Vaccine Initiative. Lots of public and government partners, you can read them for yourself. And we engage the private sector as well. How do we obtain this funding? Well, in some instances, we cultivate relationships with a sponsor like the Wellcome Trust, and we do that over many years. But for most of our opportunities, we're actually constantly looking for calls for proposals that's cocok with what we need to do and what we'd like to do and what's locally driven. That's a constant search and seek award exercise. So we understand our well-known partners and we know what they want, and we try to fit and compete, therefore, for what they want. And for others, we investigate and try to gain that understanding of whoever the partner might be, I should say the sponsor. We also understand and accept all funders' need for risk mitigation. What does that mean? We want to be able to give them reasonable assurance that there will not be research abuse, dishonesty, negligence, malfeasance, or any unlawful behavior, right? Every time a sponsor gives you money, they're putting their reputation on the line, right? And we have to actively reassure them that they're not taking an unacceptable risk with us. And we work very hard to maintain that. So we carefully cultivate a track record of research funding successes. In other words, people give us money and we didn't embarrass them or ourselves. You know, we delivered the goods. And we do that by having well-trained, competent, and fairly compensated critical task staff. There's certain things you have to get right each and every time. We call that a critical task. And we cultivate on our staff the people who can do that consistently every single time. We include legal and efficient fiscal administration of grants among our critical tasks. You must be able to account for the funds that you've been given. And you must be able to use the funds you've been given in an efficient way. And finally, we diligently publish our findings, highest impact as possible, in a timely manner. So how to work with us? This is actually very simple. It's two different models. The first one here is we have an idea, that is anybody who works in OUCRU, that we think might be interesting to our partners, a particular partner. So we engage that partner. We say, hey, this is an opportunity. Here's the idea. What do you think? And if this is interesting to our partners, then we develop a funding strategy, a proposal that's typically funded through Oxford because it's the easiest way, honestly. And if successful, we go on to protocol development, approval, and implementing the project. It's really that simple. But we also, sometimes people come to us with a research idea and a funding opportunity, and they are applying for the research money, not us. We're just a partner. That's fine. We love those opportunities. In which case, the funding goes to the partner, not through Oxford University. Otherwise, it's the same. This complex diagram illustrates those two models of people coming to us with research ideas and their own funding. We engage them. We're happy to do that. And we have ways of doing that through contracts. And then our own OUCRU-driven research, where it's the same thing, only we're the ones receiving the funds and administering them, but it's the same collaborative work, just coming from different directions. And you can see in that connection to FKUI and EMERI that we depend quite a lot on our partner for many important things. The KITAS and FRPs of our foreign staff, the regulatory oversight from BPOM, critical. Ethics oversight, we can't do anything without that, and we're dependent on FKUI for it. And of course, senior collaborators, physical space, and shared capacities. So this is my last slide. And I just want to show you what I look for as the director in terms of our outputs, because this is what our sponsor and my boss in Ho Chi Minh City looks for as a measure of our success. Grants, awards, of course. If we're not getting grants and awards, then we're not doing research and we shouldn't exist. But the grants and awards for equitable research partnerships with our local partners. That's a metric of success. Technical training and certifications of our staff and our partners who engage us on projects. The academic advancement of masters, PhDs of our own staff and our partners. We strive for both. Institutional relationships and capacity building of FKUI and others, as I've mentioned before, driven by research projects and their products. Collaborative, productive engagements with local partners that can be educational, it can be community engagement, and of course, technical peer-reviewed publications that in the end translate to policy engagement and impacts that translate to better health. This is what our sponsors look for to determine whether we are being successful or not, these things. And with that, I think I'm done. Yes, thank you.
Thank you, Prof. Kevin, for your presentation.
Agenda selanjutnya merupakan penyerahan simbolis, yaitu plakat dan hasil penelitian dari kerjasama penelitian antara FKUI dan OUCRU ID. Kami mengundang ke atas panggung Dekan FKUI Prof. Ari Fahri Alsyam dan Direktur OUCRU ID Prof. J. Kevin Bair.
The first placard is presented by Prof. Kevin to Prof. Ari as a symbol of research collaboration between FKUI-OUCRU ID and to commemorate this 6th DROSSI Appreciation Day.
Last, Professor Ari Fahri Alsyam, as the Dean of FKUI, presents a souvenir for Prof. J. Kevin Baird to symbolize the support and collaboration from FKUI to OUCRU ID. Terima kasih. Para profesor, kami persilahkan untuk kembali ke tempat duduk.
Esteemed guests, we now reach our main agenda of the event. Our first topic will be on geospatial epidemiology research. For this discussion, we would like to invite onto the stage Dr. Iqbal Eliazar, Master of Public Health, Doctor of Philosophy, Dr. Helen Dewi Prameswari, Magister Administrasi Rumah Sakit, and Prof. Dr. Badriul Hegar, Spesialis Anak Konsultan, Doctor of Philosophy, as the moderator of the session. Before that, we would like to invite all of you to do photo sessions. To all professor and VVIP members, we would like to join into the stage. For the first discussion, we again would like to invite to the stage Dr. Iqbal Eliazar, Master of Public Health, Doctor of Philosophy, Dr. Helen Dewi Prameswari, Magister Administrasi Rumah Sakit, and Prof. Dr. Badriul Hegar, Spesialis Anak Konsultan, Doctor of Philosophy, as the moderator of the session. I will now pass the sessions to our moderator. Please welcome Prof. Hegar.
Okay, thank you very much for the time. I would like to start for the first session of the DROSSI Appreciation Day today. For the first session, we have two speakers. First, Pak Iqbal and the second, Bu Helen. Now, I would like to invite Pak Iqbal first as the first speaker. So, Pak Iqbal, the complete name is Iqbal Eliazar, MPH, Doctor of Philosophy. His current position as the Geospatial Epidemiology Program Manager, OUCRU Indonesia as well. He earned his Doctor of Philosophy in Geospatial Mapping of Malaria from Oxford University. He concentrated on biostatistics, disease surveillance, spatial epidemiology, and he also interests in big data analysis in population health, geographic analysis of infectious and non-infectious disease, and also estimate of the burden of disease and the impact assessment of mobile and migrant vulnerable population on the spread of infectious disease. He has been a member of the Malaria Technical Working Group since 2014, serving the Indonesian Ministry of Health and also the Global Fund for AIDS, TB, and malaria. Please, Pak Iqbal, for the time to present your lecture.
Tes 1, 2, 3. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi Bapak Ibu sekalian. It's very grateful for me to be here. I think it's a good opportunity for us delivering our perspective, collaboration in the future. So if I would like to conclude our geospatial epidemiology research in one mission statement, I would like to say this one. So we aim to focus on developing the capacity, as Prof. J. Kevin mentioned, that the capacity, the human capital investments, in what areas? Industry areas, spatial epidemiology, quantitative methods, and mathematical modeling to support the evidence-based public health decision. So we like to connect, we would like to bridge between research, policy, and as well as the implementation. That's why I'm very happy, I'm very grateful to be here, because Dr. Helen, as the National Director of Malaria Control Program at the Ministry of Health, able to be here and also witness our collaboration for such a long time. So the next slide, this one. Ini ya, oke. Seperti sudah Bapak Ibu bisa lihat tadi, bahwa jika kita melihat OUCRU sebagai suatu entitas organisasi riset, ada dua blok yang harus dilihat. Yang pertama adalah riset yang fokus kepada pasien, patient focused research, and another block is population focused research. Di grup kami fokus kepada population, riset terhadap populasi. Itu range risetnya itu sangat luas, mulai dari surveillance, epidemiologi, kemudian juga ada social science, anthropologist, public health, climate, including mathematical modeling. Dan juga termasuk sebagai bagian dari itu adalah health economics, for example. Kami ada di bagian yang fokus kepada riset-riset populasi. Kemudian kalau kita bicara output, itu sudah ada listing, model-model outputnya tidak hanya berupa publikasi saja, tapi juga termasuk kepada dataset baru, adanya dataset baru, atau mungkin device baru, coding baru, termasuk juga ada terkait dengan policy communication, yang terkait dengan mungkin dengan policy implementation. So this is part of the output of the research organization. Nah, bagaimana kita melihat impact-nya? Impact-nya sudah bisa di-listing di sini. Salah satu di antaranya adalah bagaimana kita memperbaiki, mungkin baik itu local, nasional, atau regional, ataupun international guideline. Itu bagian daripada impact yang diharapkan dari suatu riset organisasi. Next slide. Okay, I think I'll go this one. So, there are several business core of the geospatial epidemic research. There are three actually. The first one is generating a knowledge landscape, especially focus on the infectious disease. Nah, ini termasuk bagaimana kita mengkuantifikasi beban dari masalah kesehatan yang kita hadapi di Indonesia, terutama untuk penyakit infeksi, dan mengakses risk factor yang terkait dengan beban itu. Kemudian kedua adalah bagaimana kita menghasilkan suatu peta yang high spatial resolution yang bisa mengidentifikasi di mana hotspot, di mana masalah itu terjadi, dan kenapa itu terjadi secara terus-menerus. Yang ketiga, memang kita sedang membangun untuk modeling, bagaimana kita bisa membantu untuk menilai adanya dampak dari satu intervensi yang dilakukan di level populasi. Kemudian juga kita lagi memulai untuk memanfaatkan serosurveillance capacity, terutama untuk penyakit-penyakit yang terkait dengan vaksinasi. Nah, dua hal lainnya itu adalah bagaimana kita memperkuat kapasitas riset kita dan juga policy engagement, baik di tingkat lokal, nasional, dan juga di regional. Dan sudah pasti bahwa kami ingin membangun kapasitas juga untuk bisa membantu studi-studi yang terkait dengan studi epidemiologi, clinical trials, tidak hanya di dalam unit, tapi juga di luar unit. Jadi kalau Bapak Ibu, if you sometime remember about mapping, statistics, and modeling, there are three keywords of us. So please do remember us. So itu seperti tiga kata yang menjadi top of mind dari our program. Kemudian ini tim kami. Sekarang ada 11 orang, ada 3 PhD, 2 PhD student, 2 master, kemudian 2 master student, dan 2 BSc. Backgroundnya memang bermacam-macam, ada dari statistician, epidemiologist, mungkin ada modeler juga, ada geospatial analyst yang ahli di remote sensing, ada social science dan database spesialis. Nah, ini tim kami baru 11 orang. Harapan kami memang mungkin bisa berkembang 2 atau 3 kali lebih besar untuk 5-8 tahun ke depan. Kemudian kalau riset project Bapak Ibu lihat di sini, ini sebagian dari riset yang sedang kami lakukan, saya membaginya menjadi kurang lebih 2. 5 bagian atas itu adalah riset-riset yang related dengan malaria, yang mungkin merupakan fondasi dari program kami. Sedangkan yang berikutnya itu memang terkait dengan insiden waktu itu, dengan pandemi, dengan COVID, di mana kita mulai mengambil melakukan penelitian atau analisis yang terkait dengan COVID. Dan terakhir kami coba suatu hal yang baru, yaitu climate sensitive infectious disease, terutama yang terkait dengan perubahan iklim di kita, di Indonesia. Ini salah satu program kerjasama dengan Kementerian Kesehatan, ini baru sekitar 2 bulan yang lalu, di mana Kementerian Kesehatan sedang mencari cara baru setidak-tidaknya untuk mengatasi masalah malaria di Papua. Karena masalah malaria di Papua sangat luar biasa. Ini dengan ada pilot Mass Drug Administration, MDA untuk malaria, di 2 kabupaten di Jayapura dan juga di Kerom, bersama dengan Ibu Dr. Helen, ini ada Dr. Michael Christian dan Pak Adi, yang membantu kami untuk mendampingi Kementerian Kesehatan di sini. Ini baru sekitar 2 bulan dan berharap kita bisa lihat sampai dengan dampaknya. Apapun yang terjadi, ada atau tidak dampak, tapi kami mendampingi Kementerian Kesehatan untuk mengakses ini. Kemudian kita juga mendapatkan funding dari WHO, ini juga dana funding dari Global Fund, untuk membantu Kementerian Kesehatan memahami karakter mobile on migrant population. Jadi the last challenges of the malaria emergency in this country itu akan datang dari tipe populasi seperti ini. Indigenous population, minors, forest workers, and including the military forces who come back from deployment in Papua, this is also the problem. Kemudian juga ada travelers, short travelers. Nah, Kementerian Kesehatan ingin mengetahui bagaimana cara terbaik untuk melakukan upaya pengendalian malaria pada populasi seperti ini. Nah, ini kita sedang proses, sudah selesai. Ini sedang proses untuk publikasi beberapa artikel terkait dengan ini. Kami melakukan juga studi qualitative studies, wawancara dengan mereka untuk memahami bagaimana pola perilaku treatment seeking behaviors of those type of the mobile migrant population. Jadi Dr. Asik Surya itu adalah National Director of National Malaria Control Program at the time, dan Dr. Herdiana itu dari WHO sebagai grant sponsor. Di sini ada Bu Leni dan Ibu Rosa yang lead program ini. Kemudian kami beruntung juga, alhamdulillah, selama pandemi kemarin, sebenarnya sudah mulai 1 tahun sebelumnya, kita dapat funding dari Australian DVET melalui University of Melbourne untuk memperkuat kapasitas dalam modeling dan quantitative method. Jadi ini bisa cover untuk 4 orang staf kami selama 2 tahun. Kemudian 2 beasiswa untuk ke Mahidol University, 1 dari OUCRU, 1 lagi dari Kementerian Kesehatan sebagai partner kami. Kemudian juga ada fellowship dan ada beberapa course di Jakarta, di Jogja, dan juga di Bali saat itu. Prof. Ernilwan jika hadir di sini, beliau sangat membantu kami menyiapkan letter of support untuk kolaborasi ini. Jadi thanks to Prof. Erni dan thanks to Emery juga sebenarnya saya tidak langsung membantu kami untuk mendapatkan ini. Dr. Siti Nadia saat itu adalah sebagai direktur untuk pengendalian vektor penyakit di Kementerian Kesehatan. Nah, Prof. Jody dan Prof. Ivo adalah partner kami dari University of Melbourne yang kita bangun sistem ini bersama-sama. Salah satu publikasinya di Lancet melihat bagaimana keragaman malaria di Papua. Nah, ini luar biasa, kesenjangannya sangat besar. Kita melihat analisis itu per fasilitas kesehatan. Kemudian ada juga nanti Pak Rahmat di sini. Ini juga kerjasama dengan bagian dari program ini untuk melihat sebenarnya seberapa dampak apabila implementasi dari mungkin Primaquine atau Tafanoquine itu di rolling, contoh di Papua, seberapa besar dampak dari radical cure itu bisa menurunkan Plasmodium vivax, infeksi dari Plasmodium vivax ini. Bapak Ibu sekalian, ini juga baru selesai dengan Kementerian Kesehatan juga dengan IHI dapat funding dari FINE untuk melihat seberapa efisien seandainya apabila GSPD test ini itu dideploy di satu pulau, satu wilayah, bagaimana seberapa banyak fasilitas kesehatan yang harus dilengkapi dengan kemampuan ini. Ini tidak hanya untuk malaria sebenarnya, kita bisa coba untuk TB, HIV, dan segala macamnya. Pendekatan lebih berbasis kepada modeling, geospatial epidemiologi, tapi juga mengandalkan data-data dari Kementerian Kesehatan. Ya, ini di-leading oleh Dr. Ihsan Fadila di sini dan Mbak Karin. Kemudian ini saya melihat ada beberapa college dari Universitas Sumatera Utara. Di sini ada Dr. Henry dan Pak Yuda di sini untuk membangun model surveillance terkait dengan Plasmodium knowledge. Ini Plasmodium kelima di manusia dan itu menjadi masalah sebenarnya di Pulau Sumatera dan Kalimantan. Selama ini, beberapa tahun sebelumnya, 10 tahun, 15 tahun sebelumnya itu luput dari perhatian kita. Dan inilah masalah kita untuk eliminasi malaria. Kemudian ada juga serosurveillance, ini baru. Ini kita prosesnya sekarang, Prof. Hegar, ini baru di etik, ya. Jadi ada 3 orang dari IMERI, ada Dr. Betty, Prof. Rino, dan Dr. Nina sebagai kolaborator dari kita. Serosurveillance ini inginnya kita ada di 15 rumah sakit dalam waktu 3 tahun. Nah, untuk 5 tahun pertama ini kita ekspektasi dulu untuk 5 rumah sakit, tapi kita mau expand. Fokusnya masih tiga penyakit, tapi kita mau sebenarnya ingin lebih besar lagi. Tidak hanya tiga penyakit, tapi mungkin 15, 20, sampai 30, tergantung dari teknologi yang tersedia. Kemudian Bapak Ibu sekalian, ini ada juga baru dipublikasi, ini Dr. Henry sebagai first author, kita mengajak sebenarnya teman Dr. Tiara, beliau adalah direktur untuk TB, program nasional. Anda bisa bayangkan bahwa di Kementerian Kesehatan itu luar biasa banyak data, tapi belum dieksplorasi, belum didokumentasikan menjadi satu produk ilmiah untuk memahami itu. Jadi kami kerjasama dengan TB National Control Program melakukan kajian ini. Ini sudah publish. Kemudian ini juga menarik, kerjasama dengan Dinas Kesehatan DKI. Jakarta adalah epicenter COVID. Datanya luar biasa. Jutaan data point. Nah, salah satu core kita, key collaborator kita adalah Dr. Nabila Salma dari Dinas DKI yang memberikan akses terhadap jutaan data point itu. Ini ada Mbak Evelyn di sini yang bantu untuk data manager, Pak Henry Sorenda, Dr. Henry Sorenda juga lead untuk analisisnya. Jadi kita bisa melihat bahwa ternyata di kementerian kita, Dinas Kesehatan kita itu punya banyak data yang kita bisa eksplorasi sebenarnya untuk memahami apa yang terjadi di populasi. Nah, jadi memang selama ini mungkin tidak banyak ya, atau mungkin hanya penelitian kecil-kecil. Nah, kita mengharapkan itu bisa di-leverage tidak hanya untuk DKI. Kita masih punya 37 provinsi lagi. Nah, mudah-mudahan bisa dibantu untuk bekerja sama memanfaatkan data tersebut. Kami juga terlibat dengan Institute Health Metric of Evaluation, University of Washington. Kami sudah pernah perkenalkan dengan Prof. Hegar waktu itu untuk melakukan kolaborasi lebih intensif lagi dengan grup ini. Salah satu publikasi adalah ini, memahami disparitas masalah kesehatan di Indonesia pada level yang lebih granular atau pada level yang lebih rendah. Nah, sekarang baru sampai level provinsi, ekspektasi kita adalah sampai level kabupaten kota atau mungkin yang level yang lebih rendah lagi. Di Amerika, mereka sudah melakukan itu sampai level county. Nah, di Indonesia belum. Jadi masih ada ekspektasi future work lagi untuk melakukan analisis ini lebih jauh. Di sini ada Prof. Nafsiah Boy sebagai advisory kita untuk di Indonesia. Nah, ini kita kami baru submit tanggal 16 November kemarin, mohon doa restunya, mudah-mudahan seandainya ini granted, setidaknya kita bisa fokus untuk melihat ini. Artificial Intelligence Driven untuk geospatial analytic, untuk melihat 2 masalah penyakit yang terkait dengan iklim, leptospira dan dengue, khusus untuk di Jakarta. Nah, ini mudah-mudahan 8 tahun kami mengajak Dr. Betty sebagai kolaborator kami, Prof. Hegar. Jadi kalau policy engagement tadi, output, kami cukup variasi, sejak tahun 2020 kurang lebih 30 publikasi. Ini adalah contoh-contoh publikasi juga. Namun kami juga belajar bicara dengan media, terlibat dalam diskusi dengan jurnalis-jurnalis, sehingga bisa diliput dalam beberapa media. Nah, ini adalah daftar list media selama COVID, di mana hasil analisis kami, hasil kajian kami kemudian diterbitkan, disampaikan kepada publik. Sebagai ini bagian dari public engagement. Mungkin terakhir kami juga ada training, ini dari SPAP, cover untuk training di sini, di Emery. Tapi kita juga akan punya 2 kesempatan lagi. Pertama untuk software R statistik, kemudian terakhir itu ada geospatial R, itu sudah ada fundingnya, mudah-mudahan untuk tahun ke depan kita bisa lakukan 2 kali di sini, Prof. Hegar, di Emery. Terakhir, slide dari saya. Kami sebenarnya membantu juga, kami diundang oleh Kementerian Kesehatan, sudah mungkin 5 tahun kebelakangan ini, atau lebih, untuk membantu mengajarkan Geographic Information System. Jadi bagaimana menggunakan data, kemudian divisualisasikan dengan software ini, untuk masalah-masalah mereka. Nah, saat ini kita mengundang memang dari provinsi, kabupaten, dan juga dari puskesmas. Setidaknya kami sudah diundang dari Aceh sampai dengan Papua, thanks to the Ministry of Health. Saya pikir itu mungkin Prof. Hegar. Terima kasih banyak. Assalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih Pak Iqbal untuk presentasinya. Memang kalau kita ngomong geospasial, epidemiologi suatu hal yang sangat challenging dan menantang ya. Dan kita telah mendengar Pak Iqbal berbagi pengalamannya dengan berbagai penelitiannya. Dan terima kasih, kolaborasi kita juga semakin baik, semakin waktu. Dan saya yakin akan banyak pertanyaan ke Pak Iqbal nanti. Kita undang pembicara kedua, yaitu Bu Helen. Dr. Helen Dewi Prasmaweri, Mars. Saat ini beliau sebagai Head of Malaria Control Program, Kementerian Kesehatan Republik Indonesia. Sebetulnya Bu Dr. Helen ini sudah melakukan kolaborasi riset dengan OUCRU sejak lama, yaitu sejak 2020, ya, sejak beliau sebagai salah satu tim kerja dari malaria pada saat itu. Beberapa penelitian kolaborasi telah dikerjakan bersama dengan OUCRU dan salah satunya saya lihat adalah Development of Strategic Intervention for Malaria Among Mobile and Migrant Population Indonesia since 2020. Sejak terus berlangsung ya Bu ya, masih? Baik. Beberapa publikasi juga telah dicapai dan dipublikasi pada beberapa jurnal internasional dengan high impact yang tinggi. Silakan Bu Helen.
Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Our distinguished Dekan Fakultas Kedokteran Universitas Indonesia, Direktur OUCRU Indonesia, dan para undangan dan para guru besar serta Bapak Ibu yang berada pada ruangan ini pada pagi hari ini. Terima kasih sekali kami dari Kementerian Kesehatan, saya dengan Helen Dewi Prameswari, saya sebagai Ketua Tim Kerja Program Malaria di Direktorat Pencegahan dan Penyakit Menular. It's an honor for us to be here this morning to share about malaria program to all of you. Maybe many all of you not hear about malaria for a long time, but today, this morning, I will share about the progress and challenges in malaria program and also our collaboration with OUCRU Indonesia and Fakultas Kedokteran Universitas Indonesia. Dan pagi ini saya juga akan menyampaikan terkait dengan berbagi pengalaman terkait dengan penelitian yang dilakukan bersama OUCRU dan sebagai bridging atau penjembatan antara para saintis dengan pengambil kebijakan dan bagaimana semuanya bisa diimplementasikan. Ya, dalam slide ini mungkin Bapak Ibu semua dapat melihat bahwa Indonesia berharap bisa mencapai eliminasi malaria di tahun 2030. Dan pada tahun 2016 yang lalu Indonesia dilihat oleh WHO merupakan negara yang cukup luas, sehingga pada tahun 2016 tersebut WHO memutuskan bahwa Indonesia dapat mencapai eliminasi tidak langsung sebagai eliminasi nasional, tapi bisa dilakukan sesuai dengan regional. Dan akhirnya dibagilah regional di Indonesia menjadi 5 regional, yang dimana pada masing-masing regional ini dibentuk berdasarkan kemiripan dari status endemisitas malarianya, bagaimana kemampuan layanannya bekerja, serta bagaimana komitmen yang ada di wilayah yang masing-masing menjadi regional tersebut. Di mana regional pertama yang diharapkan bisa mencapai eliminasi malaria adalah regional Jawa dan Bali, di mana saat ini sudah mencapai 99% regional Jawa Bali yang sudah bebas malaria. Harusnya regional Jawa Bali itu sudah bebas malaria di tahun ini, dan namun di tengah jalan, detik-detik menjelang tercapainya eliminasi malaria di regional Jawa Bali, tiba-tiba di satu kabupaten di Jawa Tengah, yaitu Kabupaten Purworejo, terjadi KLB malaria di sana. Sehingga yang tadinya sudah bebas malaria selama 3 tahun, tiba-tiba ada peningkatan kasus, sehingga regional Jawa Tengah, untuk regional Jawa Bali, akhirnya tidak dapat lulus ya, melewati target yang diharapkan, yaitu tahun 2023 bisa mencapai eliminasi malaria. Tapi tidak apa-apa, saat ini di Purworejo juga sudah berhasil menanggulangi, dan kasus di Purworejo saat ini sudah pelan-pelan sudah mulai menurun. Dan regional lainnya, di sini ada regional Maluku dan NTT. Di sini sudah tercapai 12 dari 33 kabupaten kota di wilayah regional tersebut, serta regional Sulawesi, Sumatera, dan NTB. Di sini sudah mencapai 84% dari regional tersebut yang sudah berhasil mencapai sertifikat eliminasi malaria. Selanjutnya adalah regional Kalimantan dan Maluku Utara, di mana sudah 45 dari 66 kabupaten kota yang sudah berhasil mencapai eliminasi malaria. Dan yang terakhir adalah regional Papua, di mana untuk regional Papua ini pada akhirnya tahun ini, tahun 2023, berhasil satu kabupaten di Provinsi Papua Barat, yaitu Kabupaten Sorong Selatan, yang berhasil mencapai eliminasi malaria. Tadinya masyarakat di Papua mungkin berpikir kayaknya tidak mungkin untuk Papua bisa mencapai bebas malaria. Namun dengan keberhasilan dari Kabupaten Sorong Selatan yang bisa mencapai eliminasi malaria, hal tersebut memberikan motivasi dan saat ini masyarakat di Kabupaten Papua sudah mulai banyak yang bergerak untuk bisa segera hidup dengan bebas malaria. Namun tantangannya memang masih sangat besar untuk di wilayah Papua. Nanti saya akan jelaskan di slide berikut. Lanjut. Kalau bicara program malaria, tentu yang pertama adalah bagaimana di daerah endemis tinggi terkait dengan faktor lingkungan itu bisa diatasi. Di sini kita lihat yang di atas sebelah kiri gambarnya adalah kejadian di Halmahera Selatan. Beberapa tahun sebelumnya adalah daerah endemis yang sangat tinggi, banyak sekali kasus malaria di sana. Namun pada saat ada modifikasi lingkungan, ada pembangunan, ditutuplah rawa-rawa yang menjadi tempat breeding site. Akhirnya saat ini Halmahera Selatan sedang menuju persiapan untuk mencapai eliminasi malaria. Ternyata pengendalian lingkungan itu menjadi hal yang sangat penting untuk kita bisa menurunkan kasus malaria di suatu tempat. Untuk itu kita membutuhkan adanya pengembangan atau bagaimana pembangunan bisa dilakukan atau pengendalian lingkungan, modifikasi lingkungan di wilayah yang dengan breeding site atau tempat perindukan nyamuk yang cukup besar. Yang isu yang kedua yaitu adalah bagaimana nyamuk di Papua. Jadi ternyata nyamuk di Papua itu berbeda dengan nyamuk yang berada di wilayah Indonesia lainnya. Kalau boleh dibilang nyamuk yang berada di Papua mungkin rada-rada mirip ya dengan nyamuk yang ada di Afrika. Dan kecenderungan dari nyamuk-nyamuk yang di Papua, mereka maunya menggigit manusia. Dia tidak menggigit hewan. Seperti berbeda dengan nyamuk di daerah lain. Mungkin kalau di daerah lain, kalau ada perumahan, maka mereka akan taruh kandang sapi atau kandang ternak di rumahnya sehingga nyamuknya bisa menghisap hewan dulu baru mencapai rumah. Namun tidak dengan di Papua. Di Papua nyamuknya cenderung menghisap darah manusia dan memang ketangguhan dari nyamuknya juga berbeda untuk di wilayah Papua tersebut. Dan kesukaan dari nyamuk di Papua itu juga indoor maupun outdoor. Di beberapa daerah nyamuk-nyamuk ada yang memang hanya sukanya indoor atau lebih memilih outdoor. Tapi kalau di Papua secara indoor dan outdoor masing-masing juga untuk di Papua indoor dan outdoor juga banyak ya, di sana. Lalu isu yang ketiga adalah bagaimana kita bisa memastikan bahwa kegiatan pencegahan bisa dilakukan oleh masyarakat dengan baik. Karena tadi itu masyarakat merasa sudah biasa dengan malaria sehingga tidak membutuhkan atau tidak kurang perhatiannya terkait dengan malaria. Bagaimana pengobatan malaria bisa dilakukan secara adekuat di sana, itu menjadi tantangan bagi kami. Untuk itu kita membutuhkan adanya promosi kesehatan yang sangat kuat atau masif, serta adanya komitmen yang tinggi dari para pemangku kebijakan di wilayah tersebut. Dan isu yang keempat adalah kita lihat bagaimana perpindahan orang. Saat ini kita lihat yang biru-biru itu adalah perpindahan orang dari Jawa ke Papua ataupun ke wilayah lainnya ataukah dari wilayah lainnya ke Jawa. Nah saat ini mungkin petanya sudah mulai berubah ya. Misal dari daerah endemis tinggi mereka ke wilayah Kalimantan Timur atau ke IKN. Karena kita juga melihat saat ini penerbangan ke Balikpapan itu luar biasa penuhnya dan kita sudah melihat perpindahan orang yang cukup banyak dari wilayah lain ke wilayah IKN. Sehingga ini juga kedepannya akan menjadi tantangan buat kita memastikan di IKN tersebut harus bebas malaria. Dan saat ini kami juga dengan BRIN dan juga dengan otoritas sedang melakukan upaya untuk pencegahan malaria di wilayah IKN. Dan untuk tantangan pada situasi ini, kita juga melakukan pendekatan-pendekatan untuk memastikan para pekerja hutan itu termasuk salah satu intervensi yang kami lakukan untuk memastikan para migran worker atau pekerja yang berpindah-pindah ini bisa tetap terlindungi dan bebas malaria. Dan ini adalah tantangan yang terakhir, bagaimana kita memastikan dari implementasi atau faktor surveillance bisa dilakukan secara adekuat, dan kita membutuhkan adanya sosialisasi, advokasi, karena memang untuk penyelesaian masalah lingkungan tidak mungkin atau sangat sulit bagi kesehatan untuk melakukan program pengendalian lingkungan tersebut secara masif ya. Namun kalau untuk pengendalian larvasida atau larva source management kami masih melakukan, tapi untuk pengendalian lingkungan mungkin itu butuh adanya advokasi yang lebih tinggi lagi untuk pemangku kepentingan di wilayah mengenai pengendalian lingkungan tersebut. Dan yang menjadi kunci utama pada hal ini adalah bagaimana kader. Saat ini di Indonesia mempunyai kader malaria sebanyak 4.000 orang. Dan kader di Indonesia sudah mempunyai kewenangan untuk bisa melakukan pengobatan serta melakukan screening dengan Permenkes nomor 41 tahun 2018 di Indonesia. Di wilayah endemis tinggi, para kader dapat melakukan pemeriksaan maupun menjadi perpanjangan tangan untuk bisa melakukan pengobatan malaria, menjadi perpanjangan tangan dari puskesmas. Inilah yang memudahkan bagi kami, di lapangan, bahwa kader-kader itu bisa melakukan pengobatan, memantau pengobatan, bahkan kami berupaya kader juga bisa melakukan pengendalian faktor ke depannya.
Bu Ellen, mohon maaf tinggal 2 menit lagi.
Oke, siap. Ini adalah bagaimana selama ini kami dengan OUCRU bekerja sama, tentunya bukan hanya terkait studi, tapi juga kami melibatkan para peneliti menjadi bagian dari program pengembangan kami. Kami mengajak di dalam kegiatan menentukan inovasi, monitoring evaluasi, capacity building. Kita selalu melibatkan tim peneliti, bukan hanya OUCRU, tapi juga universitas-universitas lain yang selama ini sudah berdedikasi untuk di dalam program malaria. Ini adalah yang kami dapat sampaikan, bahwa migran mobile population yang merupakan suatu studi yang dilakukan oleh OUCRU, dan saat ini untuk MMP ini sudah menjadi program prioritas di Kementerian Kesehatan. Kami berterima kasih terkait dengan studi yang dilakukan, karena selama ini kita memang kalau kita bisa melihat local driven itu memang betul, karena selama ini kegiatan yang dilakukan oleh para peneliti banyak berdiskusi dengan program, sehingga hasil studi yang dilakukan bisa menjadi implementasi bagi program. Itu merupakan suatu yang kami dari program sangat berterima kasih dan bermanfaat atas studi-studi yang telah dilakukan. Selain itu ada juga mengenai peningkatan kepatuhan dari pengobatan. Di sini juga sudah dilakukan studi, dan saat ini kami sedang menunggu selesainya studi, sehingga kedepannya kami bisa meningkatkan kepatuhan dengan meningkatkan dosis pengobatan primaquine serta memperpendek masa pengobatannya. Lalu cross border juga sudah dilakukan, serta data evaluasi terkait dengan mass drug administration yang dilakukan bersama OUCRU. Ini adalah slide terakhir, di mana hasil penelitian dari OUCRU salah satunya sudah menjadi bagian dari National Strategic Plan di Kementerian Kesehatan, bahwa kita harus mengintervensi para MMP atau mobile migrant population tersebut. Mungkin itu yang dapat saya sampaikan. Terima kasih banyak pada Bapak Ibu semua. Assalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih banyak Dr. Helen untuk presentasinya, informatif, berbagi kita pengalaman juga bagaimana kementerian bekerja sama dengan OUCRU ya. Baik, silakan Dok. Saya mungkin karena waktu, kita juga mulai tadi terlambat, waktu saya rasa sangat terbatas. Saya berikan 2 kesempatan, mungkin satu untuk Pak Iqbal, satu untuk Dr. Helen. Silakan. Saya rasa topik Pak Iqbal itu sangat challenging banget ya. Mungkin selama ini kita mungkin masih jauh-jauh gitu ya. Nah mungkin dengan Pak Iqbal bisa berbagi pengalaman. Silakan. Ya, Prof. Dr. Salim. Di belakang ada. Silakan Dr. Salim.
Ya, oke, terima kasih. Kalau tadi kan kegiatannya sangat banyak ya. I think very aktif ya risetnya. Barangkali saya ingin menanyakan, kebetulan saya di manajer riset ya. Catatan kami publikasi-publikasi yang terkait dengan Oxford itu masih sedikit ya. yang terkait dengan afiliasi ke Universitas Indonesia, dalam hal ini FKUI, ya. Barangkali Pak Iqbal dan Bu Helen, ya, kira-kira untuk meningkatkan ranking FKUI dan UI, bagaimana strategi ke depan nih? Saya rasa ini isu yang sangat penting kami harapkan. Terima kasih.
Wah,
Silakan Pak Iqbal.
terima kasih, Dok. Jadi geospasial epidemiologi ini memang boleh saya katakan baru ya kita di IMERI ya. Karena tidak ada juga program khusus untuk itu. Jadi saya pikir kami itu perlu istilahnya dikawinkan dengan internal. Jadi contohnya misalkan kalau di IMERI itu ada big data, kan ada ya big data ya Prof ya. Nah itu kalau dikawinkan dengan program kita itu sangat matching banget. Nah, jadi intinya adalah bagaimana kita bisa mengkapitalisasi kerjasama antara mungkin OUCRU dan IMERI. Mencari partner yang sesuai. Saat ini kami memang mungkin baru bicara dengan Dr. Betty ya dari klaster penyakit infeksi. Ekspektasi kita adalah kita mau bicara lagi dengan stakeholder dari IMERI, contohnya di big data ini. Nah ini luar biasa, potensinya luar biasa. Bayangkan kita punya sekitar 180 sampai 200 penyakit infeksi di Indonesia yang belum terpetakan sama sekali. Sampai ke level yang lebih granular. Data ada di Pusdatin, seperti tadi ya Prof. Masalah di geospasial itu adalah data dan kolaborasi. Data banyak tapi kita nggak bisa akses. Nah bagaimana kita bisa bekerja sama ini, membangun big data of population health di Indonesia. Tidak hanya untuk masyarakat sipil, tapi juga untuk di kelompok khusus, contohnya di MMP ya, Helennya ada juga mungkin di military juga. Karena movement dari ribuan tentara dari daerah endemis ke kita itu luar biasa kalau kita bisa lakukan kajian. Dan itu banyak yang kita bisa lakukan kerjasama, Pak Malisa ya. Kita bisa lakukan itu, kita bisa memanfaatkan itu. Nah, ekspektasi kita adalah tentu publikasi sebagai output kita yang paling tinggi. Nah, kita berharap bahwa kita sudah mulai dengan klaster infeksi, kita mau kerjasama terbuka dengan yang lain. Kita bangun sama-sama, kita hasilkan publikasi bareng. Mungkin itu, Prof.
Baik, makasih Pak Iqbal. Mungkin menambahkan, kira-kira menurut Pak Iqbal, apa the three most challenges of geospatial methods we can develop?
Secara teknologi tidak masalah ya, karena kita bisa catch up. Orang kita mulai tambah banyak, 3 masalah adalah data, dan data.
Sebagai closing ya, tadi saya melihat kan menarik.
Satu lagi.
Oh ada, silakan.
Ya, ini pertanyaan singkat aja.
Silakan.
Kalau tadi Pak Iqbal sangat itu data. Fundingnya bagaimana OUCRU? Nah,
kalau funding, saya pikir idealnya kalau kita berkolaborasi kita cari bareng-bareng deh. Jadi artinya kita punya riset. Jadi kita belum bangun nih komunikasi lebih intensif di antara kita ya Prof ya. Jadi saya sering ketemu sebenarnya dengan diskusi dengan Prof Egar. Wah nih kita mau bikin ini, bikin itu. Nah sekarang kita harus mulai dari pertama tuh riset hadiahnya dulu. Mungkin kita punya forum 1 minggu sekali mungkin antara OUCRU dan IMERI ini kita bicara kita mau ngapain nih 5 tahun ke depan gitu. Mungkin gitu ya. Menurut saya sih Prof. Jadi ke funding itu kita bisa cari karena funding opportunity itu sekarang sudah mulai dipetakan dari mana aja, dari Welcome Trust dan sebagainya dan mungkin dari Gates juga. Tapi jangan lupa ada satu mekanisme di mana dia tidak dilampirkan di dalam, tidak diinformasikan ke publik. Tapi kalau kita punya riset dia, kita bisa sampaikan itu langsung ke Welcome Trust ke Gates. Jadi metodenya lewat pintu belakang gitu modelnya. Gitu.
Jadi tetap OUCRU kita cari funding grant ya Pak ya gitu kan. Kita cari bersama-sama.
KSP mungkin juga siap kali Pak.
Terima kasih Prof. KSP nanti kita mencoba untuk mengorkestrasi supaya penelitian ini bisa bermanfaat untuk anak bangsa karena masalah kesehatan dan pendidikan itu 2 hak dasar yang dimana negara harus selalu hadir. Terima kasih.
Terima kasih. Ya saya tadi closing saya tadi hanya memastikan aja ke Ibu. Tadi kan ada 1, 2, 3, 4, 5 isu yang sangat bagus. Datanya kan bagus. Apakah itu work with OUCRU? Ada supporting OUCRU atau kolaboratif atau enggak, dan bagaimana kita mengawal dan bagaimana kita mengimplementasi. Mungkin bagi share teman-teman yang lain, silakan.
Ya, terima kasih Prof. Jadi memang yang selama ini dilakukan adalah pertama mungkin kalau OUCRU karena sudah terlibat di dalam proses, jadi OUCRU sudah memahami, para peneliti OUCRU sudah memahami permasalahan. Jadi studi yang ditawarkan pun terkait dengan permasalahan yang ada di kami. Lalu selanjutnya apabila kami ada permasalahan dari program, lalu kami meminta OUCRU untuk bisa membantu, pun kami bahkan bersama-sama mencarikan fundingnya untuk OUCRU gitu. Jadi memang kolaboratif ini sudah seperti itu sudah berjalan karena cukup lama ya 2020.
Dan datanya dimanfaatkan oleh pemerintah, Bu?
Dan data pasti dimanfaatkan oleh pemerintah, Prof. Ya.
Oke, baik, kita tutup acara ini. Terima kasih banyak Pak Iqbal, Bu Helen untuk share yang sangat luar biasa buat kita. Saya rasa banyak pengalaman yang kita dapat dari kedua beliau. Terima kasih, saya tutup. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Thank you, Prof. Hagar, Dr. Iqbal, and Dr. Helen. Maybe before we jump into the next session, we're going to do photo first for the first discussion. Thank you, Prof. Hagar, Dr. Iqbal, and Dr. Helen.
Topik sesi berikutnya adalah Clinical Infectious Diseases Research. Untuk sesi ini kami mengundang Profesor Dr. Ralph Hammers, Doctor of Philosophy, Dr. Dharma Imran, Spesialis Saraf Konsultan, dan Dr. Rahyu Salim, Spesialis Ortopedi Konsultan sebagai moderator pada sesi ini. Kepada Dr. Rahyu Salim, saya persilahkan.
Dr. Dharma? belum lupa nama ya. Oke, baik. Saya akan pimpin dalam bahasa Indonesia mungkin untuk Raf ya. I think you can speak bahasa ya. Ya, ya. Pertama saya mengucapkan terima kasih pada MC yang sudah memberikan kesempatan untuk kami. Yang berikutnya ya, bahwa ini adalah suatu kegiatan saya tidak langsung kepada sesi ini. Suatu kegiatan yang kita mau explore bagaimana hubungan FKUI, UI dengan Oxford ya. Yang selama ini kalau catatan saya sebagai manajer riset melihat kontribusi Oxford ya. Kalau kita bandingkan kepada FKUI itu sangat kecil dalam hal publikasi ya. In my record you have only 28 publication related to your affiliation in University of Indonesia. So we hope the next actually Dean targeted me to produce publication FKUI next year 1,500 publication. Yeah. And we hope Oxford will has 30%. Ya. Ya, jadi target kami adalah seperti yang Pak Dekan selalu menyampaikan kepada kami sebagai manajer riset untuk meningkatkan publikasi karena publikasi adalah yang memberikan kontribusi dalam peningkatan QS rankingnya UI dan FKUI tentunya ya. Kalau Oxford itu di ranking 3 ya, UI sekarang itu tadi catatan kami 248 ya. Tentu ini diharapkan ini akan bisa mendekati of course ya. Okay, we come to our session ya. There are two speaker actually ya. Ralph and Dr. Dharma. Yeah. I'll give chance first for Professor Ralph, but I would to introduce himself first. Yeah. Prof. Ralph ini saat ini senior clinical scientist, ya, Head of Clinical Infectious Disease Research Program OUCRU Indonesia. Jadi OUCRU ini sebenarnya ada di banyak negara termasuk Thailand dan Vietnam ya. Prof Ari menyampaikan waktu itu 30% ya Prof ya OUCRU ya yang di Vietnam itu kontribusinya ke Mahidol. Ya. Jadi cukup besar ya. Di Indonesia ini masih 0,% kita udah hitung ya. And then Associate Professor in Infection Disease at Nuffield Department of Medicine, University of Oxford, ya. Riwayat lainnya, Associate Professor of Infectious Disease, Nuffield Department of Medicine, University of Oxford, Head of Clinical Infectious Disease Research Program, OUCRU, Indonesian chapter, of course, Manager of the Universities of Indonesia and Oxford Clinical Research Laboratory, ya. Jadi OUCRU ini sebenarnya sudah berdiri lama, kebetulan Profesor Raf sebagai manajernya, and also internist and infectious disease physician, ya. Professor Raf will give a lecture of clinical infection disease research at OUCRU ID. Please, Tam, yours.
Oke. Selamat pagi, Pak Dekan, Wakil Dekan, Dr. Salim, Professor Hagar. It's really a great pleasure to stand here and present the clinical research program of OUCRU. And I feel I'm really among friends, so I will be more relaxed. I thought I could be very relaxed, but after the pressure that Dr. Salim put on me on producing so many publications, I'm not sure anymore. So I'm very happy to talk you through the clinical infectious disease research program, but honestly, it's too much to cover in 15 minutes. So I'm going to give you some highlights, some areas I would like to focus on that are specifically important to describe what this collaboration with FKUI is about and why it is important and what we have achieved together. So let's see. Are you running it or can I? Yeah. So clinical infectious disease research program really puts the patient central. I am a doctor, so I think in contrast to what the approach that Iqbal takes in his program, the patient is central. And in this program, we focus on prevention, diagnosis, and management of complex infectious diseases with public health impact. And the goal is to achieve better outcomes for patients in Indonesia, but in doing so also the region and globally. That means in practice, we focus on clinical trials, phase 2, phase 3, both in prevention and therapeutics. And we would like to combine that with what is called strategy trials and implementation science. That is the evaluation of biomedical and behavioral interventions that not only focus on new products, but also on how services are delivered and how diagnostics and drugs are used and how these can use to also mitigate drug-resistant infections as an important outcome. And you can look at that as a proxy for quality of care. In doing so, we strengthen local capacities to deliver clinical research of high quality and with public health impact. And at the bottom, you see 5 icons that show the pathogens that we work on: COVID-19, brain infections with HIV, tuberculosis, antimicrobial resistance, and to some extent emerging infections. I will, during this talk, focus on COVID-19 and COVID-19 and antimicrobial resistance, and then Dr. Dharma will continue to speak about tuberculosis and brain infections. So the University of Indonesia and Oxford Clinical Research Laboratory has already been introduced, and I'm mentioning it again because it has been really important as a driver to establish and create the clinical infectious disease research program. That is the home of our research, basically. It has been set up as a technical hub with a clinical trials unit, a research laboratory, and public and communication people. And these people altogether form the technical core of all the research we do. Now, first, I would like to introduce you to the people, because everything we do is done by these people that work very hard every day to deliver these high-quality products. The clinical trials unit is led by Dr. Mutia. She has already been highlighted by Kevin, and she manages a whole team of study coordinators, data managers, monitors, regulatory staff, and then at the bottom there is Dr. Desi heading the labs, also with a huge number of laboratory staff. And I only put the faces of the people here that are critical to clinical infectious disease, but this doesn't show everybody. There are more people in our lab, but I just put people that are playing an incredibly important role in infectious diseases. Then alongside that, we have our local scientists. We have postdoc research fellows and doctoral students. I just want to say here that how these students came to us and how they're developed basically comes down to they need to find a project that is funded. There are 2 people here, Licia and Yanni, that have won prizes through the OUCRU scheme for fellowships to study at Oxford. And there are 3 others that have been self-funded. They have successfully applied to LPDP and won a scholarship to study at Oxford. So these are the mechanisms of funding, but there are also other ways of funding. For example, Unke takes a PhD in FKUI and he receives funding, strategic funding from OUCRU for doing so. And Kartika and Putri, they will soon start their PhD journey enrolled in Radboud. They will be paid based from projects, so there is no scholarship involved. And 3, our partners, they're also critical, and it has been emphasized over and over again, but I just want to emphasize this again, that how important it is that all the research we do with our partners. Most of them are senior faculty of FKUI, but also other partners. And over the course of the last 6 years, the program has engaged with many departments in RSGM and other hospitals, and also different departments in FKUI, neurology, internal medicine being very central to that, but also in community medicine, clinical microbiology, pulmonology, and pediatrics. Other universities that we have collaborated intensely with is UGM in Jakarta, USU in Medan, UNPAD in Bandung, Udayana in Bali, and Atmajaya here in Jakarta. So I would now like to give some examples of how the clinical ID research program developed and how the COVID-19 research response was boosted by the clinical research program, but also vice versa, how the research response has boosted our program to develop rapidly and really become much stronger in what we do. So I think COVID-19 has, of course, led to lots of suffering, and we've all been kind of going through very rough times, but it also created research opportunities. And I think at the time when the pandemic hit Indonesia, I could say that the clinical research program was at its infancy, and there were great opportunities to set up new collaborations because of new research opportunities with funding coming in. And we were able to set this up in a collaborative way across disciplines and at scale. And as you can see here, I put some major projects that we did here in the blue row. It shows that we worked on a lot of disciplines, both in prevention, treatment, social science, and lab studies. And we've worked with many local investigators, universities, Ministry of Health, Dinkers, and NGOs, and we're able to connect with more than 30 hospitals, Puskesmas laboratories in 8 provinces, and together we recruited more than 6,000 study participants. So I think we've done some really important work that has made important contributions, and I will give you 3 examples in the next few slides. First of all, the Kopkov trial. This is a trial maybe already long forgotten by some, but you may remember that at some point when there were no vaccines, there was a great panic in finding out ways of how we could prevent being infected with COVID. And one of those ways was to use chloroquine or hydroxychloroquine. And that drug, if given in a low dose, was considered as a pre-exposure prophylaxis. So basically meaning that if you take that drug for every day, you would be protected against symptomatic COVID-19. That was the hypothesis. And the trial that was set up was actually led by Moru from Bangkok, but Indonesia was asked to partner and try to execute this trial. And in practice, this turned out to be really difficult because in the fast evolving pandemic, we faced so many challenges that were related not only to the bureaucracy and hospitals being overwhelmed with patients, but also just politics. So guidelines really strongly at some point recommended against the use of chloroquine, you may remember that, which led to halting of this trial by the regulator. There was a big challenge that fabricated research was published on these drugs, which also led to false interpretations by the medical community that this was a dangerous drug. And then the vaccine rollout started, which was great news for everybody, but not for this trial because we couldn't enroll participants any longer. So in any case, the trial stopped recruitment in December 2021, and results have been assessed and are not yet to be shared, but they will be out soon. But I think the most important thing here to highlight is that the collaboration has been so great, both with Dr. Ernie leading this and our partners in the other cities highlighted at the bottom. And the experiences in this trial have been very great in building teams, making them stronger, and responding in a very flexible way to all these challenges. So I think that experience will really help us inform future pandemic responses when it comes to clinical research. Then moving to recovery. So recovery is a trial, I think probably the most famous trial in the world that sought to very early in the pandemic, already in March 2020, to evaluate new COVID-19 treatments at a time that there were no treatments available. And in the UK, Oxford University, together with the government, were able to rapidly set up this trial and roll it out in more than 200 hospitals in the NHS system. And to date, more than 48,000 participants are enrolled in this trial across 7 countries, which makes it the largest treatment trial worldwide. Now, Indonesia was privileged to join this trial as the first country outside of the UK, and I think we can be very proud of this. And together with, again, Dr. Ernie leading on this, we built this coalition of the willing of hospitals and universities across the country that were able and willing to recruit these participants in the trial. And overall, until today, this trial has resulted in 4 treatments that are effective for the treatment of severe COVID-19. And this has been incorporated in treatment guidelines worldwide, which has probably saved lives of millions of people. And I think this is also an example of where we working together, putting together the leading faces in clinical research can really make a difference for patients. So the contributions of the Indonesian participants to this trial have led to a couple of conclusions. First of all, aspirin, colchicine, and empagliflozin as drugs have shown not to be effective against COVID. And the 4th contribution was an evaluation of the use of higher dose corticosteroids. So many people by now know is that corticosteroids have become standard treatment, also because of a publication of Recovery, but it's given typically in a dosage of dexamethasone 6 milligrams per day. Now, the hypothesis here was if we could give 20 milligrams per day, maybe that would even be better. Now, the Data Safety Monitoring Board did review data during an interim analysis and found out and concluded that this is not a smart idea for the mild cases that are only on simple oxygen. In this group, it actually led, the high dose dexamethasone actually led to excess mortality. So more people died that received a high dose of the dexamethasone. And that led to a change in the protocol. Until today, the evaluation of high dose steroids is still ongoing for ventilated patients that are severely sick. So there is still a question out there that needs to be answered and hopefully will be answered very soon. Now, Recovery is really a model for innovative, efficient platform trials, and many research areas are copying the model of Recovery to make it work for their specific area. And that is for 2 main reasons. First of all, the design was very simple, but also there are opportunities to use this trial as a platform trial, which means it can be simultaneously evaluate multiple treatments, but now going forward, it will also be used to evaluate multiple pathogens, multiple diagnoses. And I will explain a bit how that works. So people that are candidates for this trial and come into the hospital with a pneumonia, they're tested for COVID-19. If they have COVID-19, they will be randomized to a number of treatment options. You can see that here in the diagram. But if they do not have COVID-19, they will be further tested for influenza. If they then have influenza, they will be randomized for influenza treatments at the bottom of this diagram. And then the third option is they don't have COVID, they don't have influenza, but they may still be diagnosed with a community-acquired pneumonia, and that could lead to a further randomization to treatment arms for community-acquired pneumonia. And if you use this platform in an efficient manner like this, you can imagine that many important questions can be answered very rapidly, which can lead to real progress in the field of respiratory infections. So this is the future of Recovery, and we hope to remain part of this trial. Then looking at our own homegrown cohort of COVID-19 patients led by Dr. Anis, this is called the INACO cohort, we have been able to again partner with 8 hospitals that were able to contribute to this trial to characterize clinical patterns and management and outcomes of hospitalized COVID-19 patients, and specifically focusing on the changes over time, because we all know that the face of the epidemic has changed a lot since in the last 3 years. So one major finding was that we looked at Omicron infection resulting in much less severe and fatal outcomes compared to Delta in hospitalized patients. Severe disease outcomes were much less for Omicron. The same is true for 28-day mortality. And interestingly, vaccination also greatly reduced these severe outcomes. And I think that is an interesting finding specifically for Indonesia, because there have been a lot of questions about the durability and the durability of CoronaVac-based regimens and how they would protect against these severe outcomes. But it's looking quite promising based on these data. Now moving to the second theme, developing an antimicrobial resistance research agenda. This again has been a really nice collaboration with a couple of key people within the Faculty of Medicine. And we come together in an AMR work group And that work group tries to define priorities that are most relevant for our local setting. So in the last 5 years, since 2018, we've done several situational analysis and evidence aggregation exercises on the use of antibiotics, AMR, that is drug resistance, and also antimicrobial stewardship. More recently, OUCRU Indonesia has been invited to become part of a WHO core team that has developed a global research agenda for AMR in human health, which was launched in June 2023. And this again offers a very good opportunity for our efforts to be aligned with the 40 priorities that WHO has defined. Now, our prioritized AMR research agenda for Indonesia basically has 4 building blocks. First of all, assessment of antimicrobial prescribing. And Licia Limato has been a PhD student who was recently graduated at Oxford, working a lot on this area in the Explain project. Then innovative AMR surveillance. We are part of a network called ACORN. Dr. Julia at the bottom from the microbiology department is the PI on this project, where we implement innovative ways of doing surveillance of AMR in hospitals. And that is coupled with whole genome sequencing of the bacterial isolates. And thirdly, the assessment and the delivery of antimicrobial stewardship programs in hospitals and in communities. And this is becoming more of a priority for the Indonesian government to try to rationalize the use, how antibiotics are used. Dr. Robert Sinto here also shown with his picture at the bottom. He's an internist next door in the Chipto Hospital, and he's also a PhD student with OUCRU at Oxford. He is one part of his thesis is about doing a nationwide assessment of how these programs are implemented, and we're learning a lot, and that will give critical information to think about interventions in the near future. And lastly, novel trial designs for treatment of AMR infections. We are a member of the Advanced ID Network, which is a newly established network that aims to look for new antibiotic regimens to treat mostly carbapenem-resistant gram-negative infections, and also new diagnostic approaches. Then that brings me to the third theme of clinical research, TB meningitis research. This is a very long and fruitful journey, partnering with the team mostly in RSTM Neurology Department under the leadership of Dr. Dharma Imran. And I would just like to say very briefly that we have done some amazing projects together. And the most important highlight to mention here is that we recently had a publication of the ACT-HIV trial in the New England Journal of Medicine. This was a trial that looked at the use of adjunctive dexamethasone for tuberculous meningitis in HIV-positive adults. So this has been a really great achievement, and we're very proud of that. And I will leave it to Dr. Dharma in his talk to say more about this agenda and how he and his team has worked together with Oxford and OUCRU. Then scientific publications. I put this slide in especially for Dr. Salim. Clinical ID research, I started counting since 2020, to be fair, the last 3 years only. In our group, we have published 48 publications, 14 on AMR, 14 on COVID, 9 HIV, 9 on TB, and 2 in other areas. 38 of those were original research articles that included data that we have collected here. 10 were reviews, comments, editorials. And 28 of those publications included indeed FKUI authors. But going forward, as has been explained, that will quickly change and become close to 100%. Then journal impact factor above 5. So high impact journals are always important. I counted 23, but that was like a quick count. But I think it's interesting to also mention that some of these were really in high impact journals. New England Journal of Medicine, the one I mentioned, 2 in the Lancet with recovery. And then in the Lancet family of journals, we had a whole list across different areas, which also is, I think, very nice. And then 1 paper in clinical infectious diseases on COVID. And I'm not only mentioning this for the impact factor, but I'm especially mentioning this because when you publish in these journals, it means it will be read. It will be read by important people, and it will be used by doctors, and it will be used in guidelines. So I think whatever we do has impact if we are able to publish this in high impact journals. Then the vision for the next years. So I think it has been really a wonderful journey so far to work here together with partners at FKUI and other institutions across Indonesia. We've built in the last 6 years really productive relationships, and I'm really looking forward to take this to the next level in the fields of AMR, TB, HIV, and COVID-19. I think we just need more people to partner with and do even bigger things at scale and really make a big difference. The focus will remain on evaluating new technologies, point-of-care diagnostics, drugs, vaccines, strategy trials, surveillance systems. But I think it is also very important to not only look at, let's say, the hardcore, like the hardware, but also make sure we connect that with social science, epidemiological science, and implementation research to enhance the impact. And that information together is really important to use for engagement with health policymakers. What is important to them? What do we think that is important to them, and what they think is important to them? And I think that in the next years, we should take more steps for closer engagement with health policymakers. And last but not least, nurturing Indonesian clinical scientists should be at the core of what we do. And I think it is a challenge because clinical scientists typically are very, very busy doctors. They have so many tasks. To make sure that we train clinical scientists that can be dedicated to lead high impact and high quality projects, we really need to have deliberate efforts to identify those individuals and make sure they have the time to dedicate that to research. And I'm looking forward to contributing to that effort. So to conclude, just a word of thanks for the leadership and the support from the FKUI leaders, IMERI leaders, Aula research collaborators and partners, and of course study participants. And to the right, you see the sponsors and funders that have given their trust to the clinical research program. And this is again a mix of funders, both from the UK and the US, and some others that I haven't shown. Thank you very much for your attention.
Thank you very much, Professor Ralph, for your very nice presentation. Di sini kita bisa melihat saya melihat sekarang itu kita mencoba mendekatkan FKUI dengan OUCRU, dengan Oxford, dengan timnya Ralph Dan kita sangat berharap nanti staf FKUI bisa banyak berkiprah atau berperan di OUCRU Is it okay, Prof. Ralph, if many lecturer and our researcher going to join with your team Okay. Kelihatannya Prof. Ralph sih welcome very welcome. Okay, we go to the next presentation Dr. Dharma. Saya akan sampaikan sedikit tentang CV-nya Dr. Dharma. Beliau saat ini di Departemen Neurologi sebagai Kepala Divisi Neuroinfeksi dan Neuroimunologi. Sudah bergabung dengan OUCRU sejak tahun 2013 jadi sudah kawakan juga Ada beberapa penelitian yang sudah cukup banyak dipublikasi terutama di bidang HIV, tuberkulosis kemudian brain infection, kemudian bergabung saat ini di Harvest Oke, Dr. Dharma nanti akan menyampaikan experience sharing in community health research. Dr. Dharma, time is yours Silakan Dr. Dharma.
Assalamualaikum warahmatullahi wabarakatuh. Selamat siang. Yang saya hormati Bapak Dekan, Prof. Egar, Prof. Kevin, Profesor, Dokter, teman-teman sejawat sekalian. Terima kasih atas kesempatan yang diberikan untuk men-share pengalaman kami bekerja sama dalam penelitian bersama Oxford dan kelompok kerja di FKUI. Mungkin pengalaman kami pertama kali itu bekerja dengan Oxford adalah sejak tahun 2013. Jadi kalau saat ini berarti sudah 10 tahun kira-kira. Jadi pada saat itu kita melakukan penelitian yang namanya CryptoDex atau Randomized Control Trial Dexamethasone in HIV Infected Patient. Kemudian sambil melaksanakan CryptoDex itu kita juga punya penelitian sendiri yang kita buat dibangun secara lokal, namanya Jakarta Meningitis Study. Saya kira Dr. Anies sangat berperanan untuk Jakarta Meningitis Study. Nah, penelitian yang kita bangun secara lokal ini kemudian juga akhirnya bekerja sama dengan Oxford, yaitu dari Jakarta Meningitis Study kemudian menjadi IBIS, Indonesian Brain Infection Study. Jadi saya kira sesuai dengan yang disampaikan oleh Prof. Kevin tadi, jadi tidak selalu penelitian itu di-drive dari Oxford, tapi di-drive oleh kita. Akhirnya kita mengajak Oxford, Oxford juga setuju untuk sama-sama mengerjakan penelitian tadi. Itu yang kita lakukan di IBIS, kira-kira seperti itu. Nah, ini yang penelitian pertama bersama Oxford. Saya kira ya tentu kita senang dipublikasi di New England Medical Journal, ya kita senang. Tapi yang saya tangkap dari penelitian ini bukan, atau menurut saya bukan publikasinya yang paling penting. Yang paling penting adalah kita bersama-sama tim neurologi baru pertama kali pada saat itu belajar tentang bagaimana mengerjakan clinical trial secara baik, secara serius, yang kita lakukan bersama tim dari Oxford, waktu itu Oxford Vietnam. Dari penelitian ini juga kita belajar bahwa research question atau pertanyaan untuk penelitian itu tidak perlu complicated, tidak perlu sulit-sulit. Jadi pertanyaan yang sangat simple, apakah dexamethasone, obat yang juga sangat sederhana, semua dokter tahu menggunakan dexamethasone, bisa efektif untuk cryptococcal meningitis. Jadi obatnya sederhana, pertanyaannya juga sederhana. Itu dijawab dengan pekerjaan yang serius. Nggak mungkin kita bisa menjawab penelitian ini kalau kita mungkin ya sekedar meneliti saja. Jadi itu yang kami pelajari. Jadi research question tidak harus kompleks dan sulit. Yang kedua yang kita pelajari juga dalam clinical trial, seringkali kita memang harus pragmatis. Jadi clinical trial ini termasuk yang namanya pragmatic clinical trial. Jadi berusaha tidak membuat kriteria inklusi dan eksklusi yang terlalu ketat, sehingga nanti sebetulnya clinical trial itu tidak mudah diterapkan di pekerjaan sehari-hari. Jadi ini pragmatic trial yang sangat diusahakan, sangat mirip dengan pekerjaan sehari-hari. Seperti itu kira-kira. Dan ini juga pekerjaan yang berikutnya bersama tim Oxford, adjunctive dexamethasone masih sama, dexamethasone juga untuk tuberculosis meningitis. Kita tahu dokter saraf hampir semuanya begitu ketemu meningitis yang pertama kali diingat selain TB tentu saja memberikan steroid. Jadi ini suatu obat yang sangat banyak diresepkan oleh dokter-dokter di Indonesia. Jadi kita juga research dengan baik tentang manfaat dan adverse event dari dexamethasone pada pasien-pasien meningitis ini. Ini Jakarta Meningitis Study. Saya kira di sini ada banyak teman-teman yang bekerja bersama-sama untuk Jakarta Meningitis Study ini. Ini merupakan salah satu clinical epidemiologi, saya kira mungkin yang kalau nggak pertama yang kedua yang dikerjakan di Indonesia untuk memahami bagaimana epidemiologi klinik infeksi otak. Ya tentu saja infeksi otak kalau dibandingkan dengan infeksi lain mungkin angkanya jauh lebih kecil. Tetapi kalau untuk konteks rumah sakit, walaupun angkanya kecil karena pasiennya angka kematiannya tinggi, dirawatnya juga lama, seringkali infeksi otak ini juga selalu menjadi perhatian dalam rumah sakit. Ini kelanjutan dari Jakarta Meningitis Study, kita ada Indonesian Brain Infection Study, TB. Saya mungkin tidak akan menceritakan detail studinya, tapi yang saya ingin ceritakan permasalahan yang dihadapi oleh Rumah Sakit Cipto untuk merekrut pasien pada studi ini. Jadi Rumah Sakit Cipto ini merupakan, ya tentu kita tahu, merupakan pusat rujukan. Pasien-pasien yang sampai ke Rumah Sakit Cipto, misalnya pasien meningitis TB, merupakan pasien yang sudah dirujuk oleh beberapa rumah sakit. Seringkali sudah 5 rumah sakit atau bahkan lebih. Karena itu tidak mudah merekrut pasien meningitis TB di Rumah Sakit Cipto yang sesuai dengan kriteria penelitian. Nah, untuk itu kita mengajak berbagai rumah sakit lain, termasuk salah satunya Rumah Sakit Polri. Selamat pagi, Dok. Ya, jadi kita ingin rumah sakit seperti misalnya Rumah Sakit Polri itu memiliki karakteristik pasien yang tidak sama dengan Cipto, yang pasiennya kalau boleh kita bilang dalam tanda kutip lebih fresh, lebih baru kondisinya. Kalau di Cipto, pasien tadi sudah datang melalui berbagai macam rumah sakit. Jadi saya kira itu yang perlu kita kembangkan juga, Prof. Rawi Salim. Jadi kita membangun jaringan rumah sakit di Jakarta agar nanti ya tentu saja kita sekali lagi ya bisa bekerja sama dengan Oxford dengan lebih baik. Baik, boleh slide selanjutnya? Ya, ini juga kita miliki dengan kerjasama dengan Oxford, tempat sampel storage yang dikelola dengan baik. Terima kasih Bu Desi sudah mengelola ini bersama tim di laboratorium, di-manage dengan baik, disimpan, jadi kita tidak khawatir sampel kita mengalami kerusakan. Slide selanjutnya. Ini juga kita lakukan bersama tim mikrobiologi. Jadi tim mikrobiologi waktu itu masih di bawah Dr. Anis, kemudian dilanjutkan oleh tim lain. Kita berusaha memperbaiki kemampuan diagnostik, bagaimana diagnosis meningitis TB diperbaiki. Dan kami merasa kerjasama yang dilakukan oleh tim dari mikrobiologi FKUI sangat mendukung pekerjaan kami. Saat ini angka positivitas, boleh saya laporkan ke Pak Dekan, angka positivitas kultur maupun gene expert di lab mikrobiologi kita itu sudah naik, mendekati sudah 40% lebih, bahkan 44 dan 42%. Bahkan Zil-Nielsen yang dulu sangat jarang kita dapatkan juga sudah naik angkanya di laboratorium mikrobiologi FKUI. Jadi ya mungkin tadi tidak selalu hasil kerjasama antara Oxford dan FKUI itu terlihat dalam publikasi, tapi bisa juga terlihat dalam hal intangible benefit juga banyak kita lihat. Seperti publikasi PPDS ataupun research dari PPDS di neurologi. Kalau 2023 mungkin saya boleh bilang hampir 60-70% dalam bidang itu karena mengikuti proses atau mengikuti IBIS tadi. Boleh slide selanjutnya? Ya, ini juga yang sering kita kerjakan adalah clinical round bersama, terutama misalnya ada bosnya Prof. Kevin, Nah, berikut yang sekarang sedang dalam proses menjalani PhD, yang mudah-mudahan bisa bersama Oxford dan Radboud, adalah Dr. Kartika dan Dr. Putri. Kalau Dr. Kartika fokusnya terutama pada HIV-related brain infection. Kalau Dr. Putri fokusnya kepada reaksi paradoksikal dari TB meningitis. Mudah-mudahan mereka berdua bisa sukses. Slide selanjutnya. Ya, ini kira-kira kolaborator kita cukup banyak. Saya kira saya bisa mulai dari laboratorium mikrobiologi, ada Dr. Anis, Dr. Arum, dan teman-teman. Kemudian dari laboratorium virologi ada Pak Ungke. Terima kasih Pak Ungke sudah mendukung kita selama ini bekerja bersama Dr. Min. Kemudian dari laboratorium Ibu Desi, tentu saja peranannya sangat besar. Teman-teman dari Bandung, teman-teman dari Radboud di Belanda, dan saya kira mohon maaf kalau ada yang saya lupa menyebutkannya. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh. Selamat siang.
Terima kasih Dr. Dharma. Ya, saya rasa ini presentasi yang sangat inspiratif ya buat kita ya. Teman-teman yang mau bergabung dengan OUCRU nanti silakan ya. Oke, I think we go to discussion ya, because of time limitation ya. I think we have only one or chance for our lecturer to join with OUCRU program.
Yeah, thanks for the question. So I think in looking at the clinical research program and how it has expanded, there's a lot of areas that we are covering. But I think to go to the next stage, it is really important that we find people that can carry those, like Dr. Dharma is carrying, he's responsible and leading on TB meningitis. And I think every area should have those type of people. So for example, Dr. Robert Sinter is an example. He is very keen on AMR research. He's doing a DPhil, so he automatically then will become a leader after his research to have his own grants and progress. So I think all of us in OUCRU, we are very happy to speak to people and see how we can facilitate and help. But of course, we're also limited by, when we are competitive in some areas that our research focuses on, but we are not competitive in other areas. So as long as I think it is within our remit or what we can achieve, we can definitely help lecturers and staff to discuss opportunities. And maybe also there's a huge network that we can speak to, refer them to other people for ideas.
Yeah, I think it is not only for infectious disease, or non-communicable disease is also available.
Well, yeah, I think, well, the short answer is no. No, honestly, we all feel that, infectious diseases is not limited. Like, there are many examples where other diseases, conditions play an important role in infectious diseases, diabetes is being one of them. So I think as long as we have research that is focused on infectious diseases, plus important non-communicable diseases, that can be studied. But I think we have also, as a program, made a very commitment to keep infectious diseases at the core of what we do, and that is for the same reason, because we are competitive and we are good in that area. So we have to also make sure that we keep our focus on infectious diseases. But I mean, this is not cast in stone. I think we also have to look at challenges as they emerge and opportunities as they emerge. So as long as there is a link with infectious diseases, yes, it can be said. I think Anuraj, he will speak about it later. I think his program is a very good example of that. Definitely focuses on infections, but also nutrition and also on mother-child healthcare. So it's very much integrated. So yeah, listen to Anuraj's story, and maybe that's also answering your question.
Okay, maybe Dr. Rama, mungkin ada satu statement barangkali untuk mengajak barangkali, nggak hanya neurologi yang berperan ya, mungkin dari departemen lain ya, satu atau dua kalimat barangkali untuk
Iya.
inspirasi.
Mungkin kalau buat saya yang paling penting kalau kita bekerja di klinik. Bekerja di klinik untuk memperbaiki layanan mau tidak mau kita harus ikut dalam research sedikit banyak. Tidak harus kita jadi PI-nya, tapi kita ikut dalam research. Yang pertama. Yang kedua, karena kita clinician atau kita dokter klinik, maka kita inginnya memang research-nya adalah ujungnya selalu kita ingin yang clinical trial. Jadi kita ingin mempertanyakan intervensi yang kita buat. Jadi saya kira bersama Oxford itu mereka sudah sangat pengalaman untuk clinical trial, ide-ide dan lain sebagainya. Tadi clinical trial dengan masalah yang sangat sederhana tapi dilakukan dengan clinical trial yang serius. Saya kira itu yang paling penting, Dok. Kita sebagai klinisi.
Ya, terima kasih Dr. Rama. Thank you, Prof. Raf. Ya. I think we give big applause for all presenter. Thank you. Saya kira saya tutup.
Terima kasih banyak Dr. Salim, Prof. Raf, dan Dr. Dharma atas materinya. Kami persilahkan untuk tetap ada di atas panggung untuk foto terlebih dahulu.
So many new friends and old friends and friends I haven't seen in a while who are getting old like me. So wanted to talk with you, give you sort of an update about what's happening in community health research and perhaps some opportunities to work together. So this is a community health research unit in OUCRU. So our goal is to define, as I say, define specific pathways and interventions at a community level whereby human biomedical and behavioral factors shape disease impact. So this is really an integrated approach. Understand how those can be applied to community health and of course to develop scientific capacity overall. So certainly one of our main collaborators has been the Human Nutrition Research Center at DeMary, and we have several colleagues here with us today from the HNRC. Dr. Rina Agustina could not join us today, but she's been a key collaborator. And you can see this sort of integration between OUCRU and DeMary. So in fact, I am one of the leads there in HNRC for early life and adolescent nutrition. So this is an example of some of the projects that we do together. This is the BRAVE project. This is actually study in pregnant women of probiotics and omega-3 supplementation, looking at the impact actually on fetal brain development and child cognitive development. Very interesting study, enrolled around 300 pregnant women overall. And the results you can see there on the right-hand side, essentially this intervention of omega-3 fatty acids and probiotics. So it's actually the first time this sort of combination had been used looking at brain development. And we did, well, the team, I would say, did a really monumental effort in being able to do fetal brain MRIs. So pregnant women at 36 to 38 weeks gestational age underwent MRI, and they were able to quantify the brain volume development. What the study observed was improved fine motor skills in the children born of the moms that received the probiotics and the omega-3 fatty acids, improved auditory brainstem development, and a trend, in fact, toward increased brain volume, overall brain volume. And I think specifically the volume of the cerebrum. So this is really the first time such an intervention, such an effect of an intervention has been reported. And interestingly enough, this study showed a reduction in COVID-19 cases in pregnant women who received the intervention, again, comprising probiotics and omega-3 fatty acids. I think approximately a 30 to 40%. Maybe you all can correct me. I think it was around a 35% reduction in COVID cases, so which is really amazing. So this actually prompted us to look more carefully. Oops. Can you forward the slide for me? Yeah, so this, so let me just mention this other study here. So that's ongoing now. Again, a study looking at supplementation of zinc, chromium, vitamin C, and copper to look at the impact of this on and their progression to diabetes. But in this context, we're also looking at the impact of this on tuberculosis. So we know that there's this interaction between tuberculosis and diabetes, so we're very interested in that. So this is an example of a sort of interaction between non-communicable diseases and infectious diseases. Next slide. So as a result of this first result that I showed you of the impact of probiotics on COVID-19 and pregnancy, we also engaged on this systematic review. This is another type of partnership that can be executed. And we were looking at what is the impact really of any gut intervention that had been done in history, and whether there was any sort of co-impact of that on respiratory infections. Symptoms and change in RTI symptoms. So this suggests a very strong link, this sort of gut-lung axis. And if we look carefully at the immunological responses of what was happening, we see that the probiotics had a significant effect on improvement of antibody response, which we didn't see as well or as strongly in the other interventions. So again, this sort of addresses this idea, or helps to address or understand this idea. And in fact, there's a lot more going on to infectious diseases and to the equilibrium between infectious diseases and the immune system and other parts of the body's physiological systems, including the gut. So understanding how to potentiate immunity overall, resistance to infectious diseases through selective use of probiotics or perhaps other gut interventions is very interesting. Next slide. So I want to show you a result of a collaboration we've just recently completed, which is the impact of SARS-CoV-2 vaccination on pregnant women with inactivated SARS-CoV-2 vaccine and comparing that to the effect of vaccination in pregnancy with mRNA or vector vaccines, looking at maternal and child health and immune responses. So this is really, a substantial collaborative effort involving colleagues from the Summit Institute for Development, colleagues here at FKUI, at HNRC, and also with the integrated laboratory where we were able to execute integrated lab. Professor Harry is here maybe, and of course Amat, who helped to carry out a lot of the ELISpot assays that I'm going to show you. So again, it's an example how we can bring together different groups across multiple organizations, OUCRU, of course, FKUI, the Mary, and Summit Institute for Development in Eastern Indonesia. So what we observed very interestingly is vaccination in pregnancy reduced preterm birth by around 30%. Really interesting, and this effect was observed whether or not the woman received inactivated vaccine or whether they received the mRNA vaccine. And you can see reactivity there on the left is lower for the inactivated vaccines, but reactivity in general to vaccination was lower in pregnant women compared to non-pregnant ones, which is really interesting. On the right-hand side there, you see the results of the analysis for breakthrough infections. So you can see very clearly, in fact, pregnant women in general are also not as well protected. There's a higher rate of breakthrough infections in pregnant women compared to women who are not pregnant, and that is a significant effect. On the lower right-hand side, actually, this is interesting, non-significant, but potentially interesting, that in fact, there are greater breakthrough infections in women who received inactivated vaccination. And although, I think as mentioned before, both vaccinations are in fact, vaccines are in fact interesting and effective. So there's a lot more work to be done on all of this, extremely interesting. From the immunological standpoint, these are quite a lot of rain cloud plots, so we won't go through each of them in detail, but the main message is that pregnancy, in fact, suppresses vaccine response and duration. And I think this can be seen probably most clearly in this example here, I would say, of here's the spike protein ELISpot response. And here you see immunization. This is before immunization with mRNA vaccine. Here's afterwards. And if you're a pregnant woman, you have somewhat of a response to mRNA. If you're non-pregnant, you have a slightly higher response. But moving over here, if you go from, in fact, 4 weeks after vaccination to 12 weeks after, 16 weeks after vaccination, what you see is that in fact, if you're pregnant, you have a downregulation of your interferon gamma response. If you're not pregnant, however, you maintain that response. So it's very clear that there is this feedback mechanism somehow going on in pregnancy that's resulting in this suppression. So again, a lot more to be investigated there. I think the message is we need to be doing much more to understand immunology in pregnancy and protection against infectious diseases in pregnancy in general. So I want to switch gears a bit to understand, to go into some of the work related to genomics in Indonesia. So this is the GSI lab here, photo here of myself, General Doni Bernardo, Kevin Baird, who you see sitting in front here as well. That at the beginning of the pandemic, actually in March 2020, it was realized there was not a high throughput molecular diagnostic and sequencing facility in Indonesia. So we had put this proposal together, spoken with many different colleagues, and some colleagues here at University of Indonesia and others helped really to put together this laboratory, the GSI lab, which actually grew into the preeminent molecular diagnostic and sequencing facility now in Indonesia. And Dr. Ariel Pradipta, who is here, is actually with the University of Indonesia and is also a lead scientist at the GSI lab. So again, an example of these sorts of collaborations that can be created. A lot of exciting work actually is done and carried out by the GSI lab in collaboration with many different partners, a lot of sequencing, development of procedures that reduce the cost of sequencing, reduce the cost of molecular diagnostics, again, making these things viable to be available in the community. So here's an example of the type of information you can get from being able to provide low-cost services for the community for molecular diagnostics. So you can see here, we were actually able to do this analysis of examining whether there was a change in CT values during the COVID pandemic for successive spikes in transmission. So you can see here, this is the Delta wave, it's Omicron, this is XBB here. And you can see, in fact, that actually there's a change in CT values here. This change in CT values occurs here before the actual spike in the cases. And that change is typically 2 weeks in advance. So this information was shared with the government, the national government, and Dr. Ariel would regularly update them on when they thought that there was going to be an increase in cases and when there's going to be a decrease in cases. And this is part of the way the government was able to anticipate that, yes, we're in a spike phase now, but that is going to go down. So we were interested, so this is showing that more clearly, sort of the change in the, here's the Delta wave here. You can see these high CT values, which means low viral load, changing here, going down. The actual increase in cases really was occurring here. You see the same thing here with the Omicron, BA.5.2, and blunted somewhat by the time you get to the XBB.1, probably due to vaccine-related immunity. So we were interested also in whether or not, remember we were talking about diagnostics, and whether or not rapid diagnostic tests could be used in some way to understand this more. And I think Dr. Ariel is going to present more in detail about this. So we're able to scan rapid diagnostics tests, look at the control line and the test line, and take the ratio of those. And in fact, this enabled us to calculate in the same way as we were doing for the CT values, to calculate a ratio of the control line to the test line. And so these are the CT values, low CT values, and here's dropping down. And in fact, we were able to, this is a simulation, in fact, based on the correlation between optical density on the RDTs and the CT values that were known. We're able to observe that, in fact, in principle, you could predict the wave just by harvesting rapid diagnostic tests and doing analysis of the optical densities. Let me skip this, actually. So I want to come to one of the final ideas here, which is genomics for all. Because we're able to bring genomics costs down and make sequencing available, in fact, this idea of public health genomics is something that emerges. So this is an approach for disease prevention where you're using genomics for preventive and promotive care. So it's not precision genomics as we normally think about, which is when you're sick, you have some genomics work that helps you identify what drug for cancer treatment or maybe some other things. This is specifically looking at genomics of persons, looking at polygenic risk scores, and helping them to gain an advantage from that. So again, it's public health genomics, genomics for preventive and promotive care. So again, GSI Lab and colleagues here at University of Indonesia playing a large role in this, and also the Summit Institute for Development in Eastern Indonesia, who we've developed a strong collaboration with for community health, is playing a strong role in this. This is the potential workflow that we see. In fact, a pregnant woman would appear for antenatal care. She would receive a genomic assessment for detection of polygenic risk scores, perhaps predisposition to hypertension, diabetes, anemia, and so forth. And then from that, being able to modulate her care plan, enhance her care plan, so that in fact she could receive improvement in care, specifically addressing those risk scores. So this is really the future of genomics at community health, and understanding how we can have much more widespread and targeted improvement of people's health at the population level. And you can see here, I've mentioned, this needs to be powered by digital health, because you need to be able to take these polygenic risk scores, create a change in the care plan, and then execute that more or less in real time. going to skip over, let me go forward. I want to discuss this then, digital health information systems. So right now in Indonesia, there's a big push for digital health, and the Community Health Research Unit at OUCRU and other colleagues have been really moving forth on this. And the Summit Institute specifically has done a lot of work in innovating and creating global change through digital health from Indonesia, essentially creating one of the first apps used for frontline health workers for antenatal care and pregnancy care, which led the World Health Organization to create a digital adaptation kit, and then a reference app, which was released several years ago for antenatal care, and now adapting all that to the HL7 standard. So what we see here is the use of these apps, helping the government, the national government, to develop apps and develop information that are based on what's called the FHIR standard, which enables full data interoperability. So this enables this type of information system to be created, wherein all frontline health workers and facilities are based on the FHIR standard, and so all the data are interoperable. So it transforms care from being provider-centered to being person-centered care, because everyone in the health system, whether they're in a hospital, a primary healthcare clinic, or a frontline health worker, they're all able to see the same health record of a person who is coming to them, and they know which elements of the care that person has received or has not received. So the goal here is, in fact, to deploy this type of system together with the national government of Indonesia and district governments across Indonesia. Here we've highlighted 10 districts, and being able to create the system that we call next generation care. And this idea actually received an award from the World Health Organization. There's a lot of excitement about scaling this up and implementing this as a trial, looking at the impact of these digital systems on reduction in infectious diseases. And I think I'll skip over this. My colleague Edward Satanto, and my student, is here, I think, and his PhD at OUCRU is really about the impact of digital health being scaled up in a stepwise design on hepatitis B transmission from the mother to the child. These are some of the geospatial things we can look at with this real-time information, understanding what's the access of various different populations to healthcare facilities, and being able then to target the care as necessary. So I think one last slide, I just want to show you so this is really the last thing I want to talk about, just to show you an example of specific studies proposed for Indonesia over the next 5 years and beyond. I'm not going to read through all of those, but it gives you an idea of sort of the different things we're trying to focus on within community health research with various different partners in Indonesia, including the University of Indonesia, national government, district governments, genomics organizations, and so forth. So creating a platform so you can do, in fact, community-based trials like hospital-based trials are done. So you saw that recovery platform. So we need something similar or better at the community level, in fact, where one can do large-scale community-based trials with only a month of lead time for preparation, because you only need to randomize, deploy the intervention, and the health system and all the other information systems are able to capture that, all the outcome information. So again, large-scale randomized trials becoming a routine thing, routine knowledge creation and generation, and a reform of primary health care in that ongoing process. And I think this is an innovation that should come from Indonesia, for all of Indonesia, and for the rest of the world. It's something that can be done now, and hopefully in the next 5 years or less, we can see that happen. Thank you.
Thank you, Dr. Anurag Shankar. So the next speaker is Dr. Ariel Pradipta, PhD. He is our staff in the Department of Biochemistry and Molecular Biology. And also now he is responsible for the quality of our animal lab facility at the IMERI. And he is also the chief scientific at Genomic Solidaritas Indonesia Laboratory, which already explained by Dr. Anurag Shankar before. So please, Dr. Ariel, you have 15 minutes. You can deliver your speech in Indonesian.
Thank you. I was gonna do it in English and Indonesian, but I can do it in both. So thank you very much, first of all, to the inspirational dekanat line, Prof. Ari, Prof. Ovi, Dr. Anis, Prof. Rayu Salim, Prof. Hegar. Also, thank you very much for my esteemed teachers. Pak Iqbal was my teacher in the training that he mentioned earlier. Dr. Kevin, Dr. Rafe, that discussed a lot of stuff with me also regarding this. And also Bu Safarina, but she went out, I think. She was here earlier, and yeah, she taught me a lot also. And also honored guests, both offline and online. So why am I here in community health research, especially since my master's is in immunobiology and my PhD was actually in host immunology from Osaka University. So realized very early in my career, mentored by Professor Hegar and Professor Budi Wiweko from IMERI actually, that there is a disconnect, not just in Indonesia, but everywhere right now, in terms of molecular discovery and then going into in-depth studies. But then there's a disconnect starting here. There's the intervention and implementation, and then community engagement. That a lot of that, in many of those steps, require feedback. And only from those combined feedback, communication, and a lot of trust, that there can be innovation. And this is why I believe that from my department currently in FKUI, which is biochemistry and molecular biology, I'm really grateful that I will be able to try to grow this together with all of you. So first, starting the story, right? What was the molecular innovation? What was the molecular discovery that we wanted to bring in? And at that time, with Dr. Anurag Shankar, we figured that there was a real difficulty in doing the genomic surveillance. And in this case, we built a model, starting from the most left image. We built a model using whatever at that time the nation had. If we simulated the viral load, the overall viral load and viral infection of SARS-CoV-2 based on numbers internationally, we found out that the TAD, turnaround time, of those samples will be up to 200 days, which is not feasible at all. There's nothing we can do from that. So we realized that there has to be something to do. And those things does not always relate to laboratory works. In the middle image, we found out together with the National bisa memastikan bahwa data itu masuk streamline, very good flow from start to end of reporting until it reaches GSAID, which is at that time the trusted platform until now, the trusted platform for global pandemic management. Jadi, and then so at the rightmost image, we can see that the number of sequences per day finished nationally increased from 0.4 per day to 43 per day, which is 40 great pride for our nation. And then applying this, we were very lucky to collaborate with, I think Dr. Trina is here right now, and with the university, oh, there she is. I'm so glad you're here. And also from the University of Sumatera Utara. We wanted to achieve two things. First is to prove that COVID is also dangerous for the pediatric community. There was a little bit of a truth issue at that time, which we want to really penetrate into. And also, we want to make sure that we can try to trace the infection. So to make things short, basically, from the most right image, we found that the detected viruses came from two distinct branches of phylogenetic tree. So based from there, we realized that we cannot blame any single cause of entry for the infection. But we need to be aware that there are ways to detect this and there are ways to prevent it. So this is where we realize that a lot of molecular science should be applicable in a very wide setting and a public health policy making setting. And then, thank you. So then the question is, how do we spread? Very interesting experience. One of our collaborator was from Sorong in Papua. Now, Sorong at that time was apparently a new province. It was not in the international registry yet. So when we submitted a sample of COVID-19 to GISAID, to call us and make sure that we're not making it up, because they did not have Sorong in their registry yet. So we had to explain it to them, we had to show to them from the Wikipedia pages and also from our government pages that Sorong is a real province. The complicated term is lateral flow rapid diagnostic antigen test, but it's basically the antigen test. So we simulated, we found out basically on the top right image there, ABC, it basically shows that we are able to obtain samples from not only swabs, nasopharyngeal and oropharyngeal swabs, but also from the strip of the antigen test itself. So we were able to extract it, we dipped it into the eluent, and then we do some heating and extraction and everything, and we were able to get results. Although the CT was higher, as shown in the blue and the reds mostly there. Then, as we wanted to expand the usefulness of this to detect the CT, we also created a method that followed Dr. Anurag's previous work on using the optical density that is shown on the strip itself, comparing between the test and the control line using any camera, because we want to make sure that any current smartphone or less smartphone cameras can take the picture and can be analyzed for the difference of the optical density. And we found that it does predict, although at this point, still to a small extent of CT range. So only those with very low CD, which is very high infection, can still be detected accurately. But, next please, thank you. But then we further use these strips for genome sequencing. And the genome sequences that we got, interestingly, if you can see on the blue, is not very good, because the blue only uses oropharyngeal swab. But those who are red, because it came from a population that actually requested PCR, they had 2 swabs done based on the protocol, which is nasopharyngeal, which is from the nose and from the mouth. And we could detect that. So there is an expanded utility there based on the kind of circle that we saw first. There's a feedback, and then we could increase the usefulness of such a common test, which is the rapid diagnostic antigen test. Next, please. So yes, at this point, I just want to thank everyone that has been very, very active in many of the collaborations. I kind of want to signal something, since I'm relatively new as a staff in FKUI, but I've been here since my MD days. Like I studied here basically. That's why a lot of inspiration came from a lot of professors here. But I'm really glad that even until now, we are still able to expand and collaborate. Side just now. So maybe just one more. Right, I'm gonna take this extra minute that I have to reiterate this, and then one more time. And then please wait, I just want to say something. All right. So after I review all this and I discuss with my previous supervisors in Japan and Newcastle, I come to the conclusion, a very philosophical conclusion, and I'll press it one more time, that the 2 very important things in research is the assets we have and the trust we have between each other. The assets does not all funding, but also to the management, to the governance that we have, as I learned in our first paper, where we realized that we need to add the capacity, and also the communications that we have, the different friends and collaborators we have in different professional associations that really wants to do good for the country. And then there's trust. Now, trust, I think, is a very interesting issue, because a lot of things in community health research has to be communicated to the people, to the ones that, to put it harshly, we use the data from, but hopefully this kind of molecular background that I have
Thanks, Ariel. I want to ask a question for Dr. Ariel. A very inspiring talk. I want to ask you maybe on your experience on how it is in a laboratory to first set it up for very high scale throughput sequencing, and then in the endemic area, post-pandemic area, go back again to normality, and continue those services in a new lab without that high demand of specific tests like COVID tests? And how do you transition going to like new directions, new areas, rethinking the business model you had in mind and all these things? Because to me it sounds like a really complex enterprise to set it up, but to make it sustainable, maybe even more complex.
Is it okay? Oh, okay. Thank you very much, Dr. Anis. Thank you very much, Dr. Rafe. Transitioning from that is an issue of, to put it bluntly, it's an issue of numbers. But numbers can come from two things, right? The same thing a lot or many different things, and then we combine it into one. So luckily, in terms of genomics at least, which is the name of Genomics Universitas Indonesia, and also the things that we're trying to push here, like Prof. Anuraj, which is Genomics for All. Luckily in this planet, the genomics, the ATCG is the same for a lot of different living beings. I'm not sure on other planets, but at least on this planet, it's the same. So there's a lot of activities in genomic sequencing that can be streamlined together. Not necessarily different samples, but it can be different targets of what they find. So a lot of genomic platforms also right now has innovated towards, for example, barcoding and reusing the flow cells, for example, and also adding many different kits and workflows to accommodate that. So to answer it simply, we add variety, but then we try to make sure that they're all streamlined to the same pipeline. That's how we adapt. That's how we do.
Yes, please.
Okay, thank you. That's very nice presentation from all of you. So my name is Yuni. I'm from Summit Institute for Development. I'm happy to be here with all of the nice expert here. I'm just
can be done. And I think another aspect is having the research itself be a vehicle for training and capacity building. So it means that I had done an informal analysis years ago, and it's never published, but I'd love for someone else to do the same research and publish it, which was essentially, it was an examination of what was the impact of large-scale trials on child survival. Any randomized controlled trial at scale, what was the impact of just implementing that on child survival? And what I noticed was that, in fact, this seems shocking, but despite the cost of doing large-scale randomized controlled field trials, they are actually one of the most cost-effective interventions to improve health, shockingly, right? And I think what this illustrates is that a lot of the current systems that are
used to improve health, frontline health workers and so forth, they're not working nearly at the efficiencies that they could be. And so I think one of the things for community health research is to focus on that, focus on capacity building, development of the systems that then are sustainable to reach a higher level of excellence, and then training persons locally who can actually achieve those. So I think those would be the three things that I would suggest as sort of axiomatic that would be necessary for any sort of community health research.
Thank you. Just a short addition. I think on top of such a wonderful concept, which I all agree for, there's also the issue of the blood, sweat, and tears of the people that are going to do it. So I think what's important is being able to relay to both the community and, talking practically, to the funders on the importance and the impact that this will give. Whether it impacts 1,000 people or 100 people, as long as we're still able to communicate it, then I think that is more important in terms of community health research.
Yeah, if I could just sort of expand on that a bit, you know, one of the challenges is persons who know what they're doing, who go through the capacity building, they're able to create change at scale at the community level, right? So often those persons with those kind of talents, they end up being hired or pulled into other jobs to like lead a program or be an administrator at you know, a UN organization or an NGO or something like that. So now their skills are removed from the community. So I think one of the things we have to do is think about how do we retain people, in fact, who want to work closely with communities, people who are talented, who have skills, scientific skills. So I think Ariel is a great example, right? Here's someone who's sort of a crossover person trained in immunology or in biomedical sciences, but is interested in doing community work and working at that level and thinking how to change things. So we need to figure out ways also to make community health research, staying at the community level, working there in the trenches, you know, making that attractive and interesting, and understanding that that's worth something, and moving into a higher level position at the United Nations or a university or something like that, that may actually remove those benefits, oddly enough. So we need to find a way for that also. Growing new talent, you know, crossover talent, retaining those persons at the community level.
Okay. So thank you very much. So because time is up, and thank you for both excellent presentation, and please give applause for both of them. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Anis, Dr. Anuraj, and Dr. Ariel. Please stay in place. We're gonna take a photo session first.
Topik sesi berikutnya adalah malaria research. Untuk sesi ini kami mengundang Prof. J. Kevin Baird, Doctor of Philosophy, FASTMH, Profesor Dr. Ernie Juwitanu Nilwan, Doctor of Philosophy, spesialis penyakit dalam, konsultan penyakit tropik infeksi, Finasim FACP, dan Profesor Dr. Dwiana Okvianti, spesialis obstetri ginekologi, Master of Public Health sebagai moderator pada sesi ini. Kepada Prof. Ovi, saya persilahkan.
Okay, good afternoon already. Maybe very late, 1 hour from our lunchtime. I hope everybody is still eager to hear, because we have two experts here that really have a long record for the experience in research. The first one is Professor John Kevin Baird, BSc, MSc, PhD. He has a long focus on Plasmodium vivax malaria, in particular on the problem of G6PD deficiency and cytochrome regarding to toxicity and efficacy of primaquine. I think Professor Kevin Bird will begin with the first lecture. Please.
Thank you, Prof. Ottaviani. At OUCRU that make everything I'm going to show you possible. We have a team of study physicians, research fellows, doctoral students, and some of the faces you'll have seen before in other projects from other people, because as I've explained before, we share people, we share resources, we work across projects. But all of the folks I'm about to show you have been very important players in the malaria. By Dr. Desi, Jarang Jowok, yeah? There's a couple there. More laboratorians, lots of laboratory work, and these are the folks who really do the heavy lifting that gives us the data that we need to make sense and impacts with our research. Next slide, please. And there's many aspects to it. Field logistics, the malaria folks, more than I think other programs, spend a lot of time out in the field, doing work in villages and clinics. Next slide, please. We work a lot with Ernie, Prof. Inga, Prof. Melva, we've worked with Prof. Rianto here in FKUI, but we also work with other partners around Indonesia, Rintis and Ari at the Eichmann Health Initiative. Prof. Iogia, we do an awful lot with, not only in malaria, but other things as well. And that's also true with Inke. We collaborate with malaria and other things. So thank you both for coming today. It's a pleasure to see you here. What is the malaria program? I'm just going to run through the things that we focus on. We do mostly randomized controlled trials, as Prof. Yanti mentioned, and Plasmodium vivax is a specialty of us, our groups. In particular, anti-relapse therapy, both in communities and in high-risk populations like TNE soldier populations. Improv, Inspector, Prima, these are some of the trials that we've done. Surrogate markers for latency in P-Vivax. This is a study involving a serological marker of carrying parasites in the liver, latency. It's an important program and public health objective. We've worked in pharmacogenetics, including surrogate markers of CYP2D6. This is ongoing work, by the way, with Mario in the laboratory. We're looking at 5,6-orthoquinone in urine as a direct surrogate marker of CYP2D6 activity. We have an ongoing and active program of malaria vaccine trials in high-risk TNE soldier populations. The current one is an attenuated, actually two different attenuated sporozoite vaccines from Scenaria in the United States. And we're now in discussion with Adrian Hill and his team at Oxford to trial their vaccines, R21, which is for P. falciparum, and RVX21, which is a currently in phase 1 trials vaccine for Plasmodium vivax malaria. And we hope to commence that trial in 2024 but probably enroll in 2025. And this is the work that Iqbal mentioned earlier. He does a lot of malaria work, but that's not all he does. And he described that work as well. I just want to take a few minutes to describe a model that we've relied upon for years now. Excuse me. This is the cover photo of a paper that Ernie published in, I think, late 2015, and the figures are from the same paper. And what it demonstrates is the fact that if you could take a population of soldiers, that's almost 500 of them in the photo, and you take them from when there's no malaria to where there's a lot of malaria, they're going to come home with hypnozoites in the liver, and they're going to be relapsing with malaria. So this is an ideal population to trial therapies against that relapse, and this is what we've done. This is not updated, but some data from the vaccine trial in a battalion. And you can see there in the graphic after 4 months that, well, you can't see the numbers, it's not percentage, but an awful lot of malaria cases in these soldiers in the field, which again gives a unique opportunity to study interventions like chemoprophylaxis and vaccines. So this, from the malaria perspective, our ability to make high impact contributions, research contributions to the control and elimination of malaria is really enhanced with this soldier model that we've been using for more than 10 years in partnership with our friends at T&E. This is a relationship that historically we've managed with our friends at the Eichmann Institute, and now we're going to be looking to our friends at FKUI to manage that relationship. And we look forward to doing that. This is very recent photos taken right over there at Ernie's professorial indoctrination. And I'm showing you Fitri's picture as well. Fitri is effectively our relationship manager with our friends at T&E. This is what it looks like in the field when the soldiers are out. Actually, this is their home base. I don't have any pictures of them in the field. This is at Bangkinang in Sumatra, and these are the soldiers that we vaccinated in that randomized controlled trial. We do strive to do the policy engagement and impacts, as I explained in my opening presentation, and thanks to Iqbal's work with the Ministry of Health, he has contributed substantially to that book you see there. I happen to be on the guidelines development group at WHO, so we make contributions and impacts there as well. So I believe this is my last slide. I just want to share where I think the malaria program can go in the coming years. I believe we will be performing practice-defining radical treatment trials for PVIVAX. And we're one of the very few sites left in the world, actually, that can do so. We will perform practice-defining acute malaria treatment trials on p-falciparum at one of the few remaining sites in Southeast Asia that's capable of doing that. I think that's in the Jayapura region of Papua. We'd like to be able to do that. And we will perform technology and practice-defining trials of malaria vaccines that are fit for purpose in eliminating malaria transmission from low endemic settings. I'll say that again, that's a really important point. Most of the vaccine trials and vaccine products against malaria that are out there today are being trialed against mortality in African children. They're not being trialed for the prevention, for the elimination of malaria. It's one thing to make children survive malaria. It's another to make adults non-infectious and protect them as well. These are two different objectives. And we will need, here in Asia, we will need to trial our own vaccines and not accept the results of vaccines in African children as ideal for Asian populations. We can't do that. And we're going to have to be able to trial our own vaccines. And I think that OUCRU, FKUI, our friends in TNE and others, we can contribute in that area. We will perform technology and practice defining trials of intervention packages fit for purpose in eliminating malaria in low endemic settings. We can do this with cluster randomized or step wedge community-based trials. So we will contribute, I believe, technical abilities and tools that the MOH will need to achieve their elimination goals. And that's all I have. Thank you.
Thank you, Prof. Kevin. I think it's very, very interested in hearing your research. And we come to the next expert. I think everybody already wait for this. Professor Dr. Ernie Cianelwan, PhD, double doctor, double PhD, internal medicine specialist, and everybody should, I think, already know about her. And the topic is experience sharing in malaria research, focusing on IDS PZV study in Indonesian Army. Please, Professor Ernie.
Baik, terima kasih Prof. Opi atas introduksinya. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Untuk mempercepat presentasi, karena kita di antara makan siang dan slides, saya akan presentasi dalam bahasa Indonesia ya Prof. So I would like to deliver my talk in bahasa Prof. Kevin, it's okay? Ya, terima kasih atas kesempatan yang diberikan. Jadi saya memang mendapatkan tugas untuk sharing mengenai penelitian yang saat ini masih berjalan, yaitu vaksin trial khususnya untuk malaria, dan kita melakukan penelitian di tentara yang tadi Prof. Kevin sudah jelaskan bahwa memang penelitian di tentara ini unik dan mungkin settingnya hanya ada satu-satunya di dunia ya, karena kita memberikan vaksin pada orang-orang yang tidak terekspos malaria secara natural, dan kita lakukan vaksinasi, kita pastikan vaksinnya bekerja, diberikan secara cukup, kemudian dikirim ke daerah dengan exposure malaria yang luar biasa, dalam hal ini adalah Papua. Dan kalau kita belajar dari pengalaman teman-teman di TNI, di sini saya tadi sempat lihat dari Dirbin, Dr. Jusron, tapi kelihatannya sudah meninggalkan ruangan, dan ada beberapa sejawat lain yang sudah tahu bagaimana beban infeksi malaria itu pada prajurit yang berangkat itu luar biasa. Jadi ini ada 2 vaksin yang kita coba, di mana vaksin ini dari penelitian sebelumnya di luar setting seperti Indonesia itu sudah memberikan efektivitas yang luar biasa, bahkan sampai pemantauan yang lama, cukup lama, sekitar 18 bulan. Ya, jadi dalam hal ini memang konteksnya ini adalah collaborative trial, jadi kerjasama antara teman-teman dari OUCRU, awalnya diinisiasi masih dalam bawah pimpinan Prof. Amin dari lembaga Eijkman, kemudian dengan OUCRU dan FKUI dan teman-teman dari TNI. Jadi yang terlibat di sini sangat banyak sekali kalau kita lihat, dan perlu dilihat nanti juga bahwa settingnya tidak hanya di satu tempat, tapi di berbagai tempat yang berbeda-beda. Ada setting di Jakarta FKUI yang kita mengatur masalah perizinan, regulasi dan seterusnya. Kemudian ada teman-teman yang ada di site sebelum diberangkatkan ke daerah operasi, yaitu di daerah Sumatera, di Bangkinang, di Pekanbaru. Kemudian ada juga site utamanya yaitu di Papua yang terdiri dari beberapa tempat yang nanti kita bisa lihat betapa ini adalah suatu proses yang luar biasa dalam pemantauannya, karena kalau kita bicara trial vaksin maka kita bicara masalah efficacy tentunya, dan yang kedua adalah safety, dan ini adalah 2 hal yang tidak bisa dilepaskan. Belum lagi adanya keterlibatan monitor yang harus selalu kita engage dalam hal ini, dalam hal pelaporan seperti teman-teman dari BPOM, dan yang tidak kalah penting on top of that adalah dari komisi etik, baik komisi etik di FKUI maupun komisi etik dari Oxford. Maaf. Jadi ini mungkin ada slide-slide yang sifatnya, jadi kalau kita lihat dalam hal ini saya diberikan amanah untuk menjadi peneliti utama yang tugasnya selain mengoverview keseluruhan jalannya penelitian mulai dari sejak dipersiapkan di awal sampai dengan tidak hanya dari sisi tim saja, tetapi juga dari sisi vaksinnya dan juga bagaimana perizinan baik dari sisi etik maupun perizinan dari BPOM tadi sudah disebutkan dari FKUI-nya itu sendiri dan keterlibatan semua pihak sampai persiapan sebelum penelitian ini bisa disosialisasikan atau diperkenalkan kepada teman-teman TNI itu semua adalah bagian dari tugas ini. Kemudian kita juga harus selalu memastikan adanya keterlibatan dari seluruh kolaborator dan pada saat sudah dilakukan penelitian baik mulai dari proses enrollment, screening dari partisipan dalam hal ini prajurit yang notabene mungkin bisa kita anggap adalah orang-orang yang sehat, maka hal ini juga harus dilakukan gitu ya karena ini terkait dari masalah hal-hal apa saja yang harus kita perhatikan sebelum kita memberikan vaksin. Itu list inclusion dan exclusion kriterianya itu begitu banyak, memang tidak disampaikan detail di sini, tapi ini adalah hal-hal yang harus kita pastikan sudah dimonitor atau dipantau sebelumnya. Dan pada saat vaksin sudah diberikan, tentu kita tahu ada reaksi cepat dan reaksi lebih lambat dari vaksinnya terkait dengan bagaimana prajurit bisa di setting di batalion itu bukan setting penelitian. Jadi kita harus juga memahami bahwa prajurit ini punya daily aktivitas yang tidak bisa kita interupsi begitu saja. Jadi kalau pemimpinan di TNI itu juga cepat sekali berubahnya. Jadi kalau hari ini kita ketemu Kepala Pusat Kesehatan Angkatan Darat, misalnya Dokter Purwo, nggak berapa lama tuh kita bisa ketemu dengan dokter yang lain. Yang akan memberikan vaksin dan memonitoring, kemudian teman-teman yang meng-unblind vaksinnya, jadi ini memang vaksinnya adalah vaksin yang masih harus dipersiapkan secara manual karena kita masih fase 2, kemudian ada teman-teman yang mengolah data, logistik, dan kalau kita lihat di sini sebenarnya wajah-wajahnya ada semua di sini, saya appreciate terhadap kerjasama yang selama ini sudah sangat baik dari teman-teman di lapangan. Kalau kita lihat di sini tim lab Bu Desi tentunya dengan Mbak Yulia, kemudian yang luar biasa Dokter Christine dengan teman-teman dokter di sini ada Dokter Indri, Dokter Rara, saya nggak bisa sebut satu-satu, tapi ini adalah mereka-mereka yang bekerja 24/7 karena kita ada di alhamdulillah mungkin sudah hampir baik. Ya, untuk exposure period saya rasa tadi Pak Kevin sempat ada satu slide yang menceritakan, tapi yang pasti yang harus dibayangkan ini adalah bekerja selama 9 bulan dengan tim yang cukup solid dan tidak bisa ada istirahatnya karena memang penugasan itu jangan
Saya rasa tidak terburu-buru, tapi memang seluruh materi sudah disampaikan oleh Dr. Erni. Prof. Erni, terima kasih. Prof. Kevin, saya rasa waktu kita untuk kita tidak terlalu terburu-buru walaupun lapar. Saya persilahkan kalau masih ada 1 atau 2 pertanyaan, please. Silakan. Kesempatan yang langka untuk bisa mendiskusikan.
Ya, terima kasih Prof. Perlu saya jelaskan